Hello, good evening, everyone. It's a great pleasure to welcome you all for this very exciting scientific webinar COUS 7 Treatment and Management of Breast and Lung Cancer. Now, it's great pleasure to invite Dr. Rajat Bajaj. He is a senior consultant medical oncology, Fortis Hospital, Noida, to welcome an introduction note. It's over to you, sir.
Yeah, I'm audible, right? Yes.
Yes, sir, you are clearly audible.
Okay, I can't start my video actually, but then that's fine. So, good evening, everyone. I thank you all for joining this evening to this two-day webinar on breast cancer and lung cancer. We'll be talking about lung cancer today on day one and breast cancer tomorrow on day two. So, we do understand that there are frequent evolutions in our field of oncology, and we as clinicians would want to keep abreast of all the new things happening around us, and nothing better to discuss this on a platform with all our colleagues so that we can share our experiences and grow wiser as to how should we go about treating our patients in our daily practice. So without any further delay, I would like to start the meeting today, and to set the ball rolling, we are going to first discuss the molecular aspects of non-small cell lung cancer. How have we improved or become better in this aspect in the last 1 decade? And to talk about this, I have with me Dr. Sunil Pasricha, sir, who's a senior oncopathologist at Rajiv Gandhi Cancer Institute, and sir, loads of experience about how we deal with the oncopathology part of NSCLC and how things have evolved in the last 10 years. He will be the best person to tell us about that. So, sir, good evening once again, and over to you.
Yeah, good evening. Thanks, Dr. Rajat, for the kind introduction. So, can I share my slides?
Yes, sir.
Okay, so I'm just putting into the full screen mode.
Yes, sir.
Okay, so they are moving.
Yes, sir. It's moving.
Okay, so I'll be talking about the biomarker testing in the NSCLC, how we have changed over a decade. So I'll be talking about these predictive biomarkers. So before starting, I'll want to emphasize that tissue is always the issue. So the endoscopist or the radiologist should be encouraged to perform multiple sampling. Ideally, 5 cores are good enough. And pathologists should manage these cores wisely and judiciously, not to put all the cores in the single block. Otherwise, when testing, all the blocks will be depleted simultaneously. So we have to economize on the use of the tissue, and each core of the tissue has to be blocked separately. Initial diagnosis is completed using 4 sections. We have to rely on morphology and limited IHC. So as far as possible, go for upfront or reflex molecular testing, which may be even IHC or FISH-based for the specified markers. And why it is important? Because the appropriate number of the tissue sections are cut for the first time. So what happens is that there will be no repeated trimming of the block when you again take the block into the microtome for cutting, and there will be no wastage of the tissue. And also the turnaround time will also be controlled. So we all know that 90% of the lung cancer, they are non-small cell lung carcinoma, and the role of pathologists in this current era is not only just to diagnose lung cancer, but also to identify the driver mutation so that the patient can be put on the targeted therapies. And why it is so important? Because that can be easily taken from this the lung cancer mutation consortium, in which 733 patients were analyzed for the 10 genes. And what the results was that one can see in the graph that the patient in which the targets were identified and they were put on the targeted therapy, as highlighted in this orange graph, we can see there is a good prognostic separation of the curves as compared to this orange curve. When the patients were put on the targeted therapy, the targets were identified, as compared to when no targeted therapy was given or when no driver was identified. So the consortium demonstrate that the best outcomes, they are seen in the patients with identified drivers placed on targeted therapy, with a 3.5-year median survival. That was commendable. And we also have to understand there is a potential application in the uncommon mutation also beyond EGFR and ALK. As we know that there is a potential application in this ROS, RET, BRAF, MET, ERB2. So in all, they all makes around 15% that makes of these rare mutations. And majority of these common and uncommon driver mutations, they are actually targetable with the FDA approved agent or on a clinical trial. Like we have seen recently, these EGFR exon insertion mutations, the amivantamab has been approved by FDA, and for HER2 trastuzumab deruxtecan is there, and for the KRAS, sotorasib has been approved for the G12C. So we have seen there is an evolution of therapy in the lung cancer for the last decade, and it has proved that it is not a single disease, but rather a spectrum of many. So a biomarker testing in the lung cancer has always been a moving target. And in 2013 guidelines, just a decade back, so there was recommendation to do only for EGFR mutations and ALK gene fusion, and there was insufficient evidence to support NGS panels. But in 2018 updated guidelines, besides EGFR and ALK gene fusion, there was a recommendation to go for the ROS1 gene rearrangement and also to add BRAF, ERB2, MET, RET if doing a large panel. Besides that, NGS panels were preferred over a single gene test when we are going beyond EGFR, ALK, and ROS. And also the use of cell-free DNA, that is a plasma genotyping, is for testing when tissue was unavailable. And ASCO NCCN guidelines extended the recommendations to include the routine first-line BRAF mutation testing. So in a nutshell, these are the two categories. One is the minimum necessary, which is must-do test, comprising of PD-L1, IHC, EGFR, ALK, ROS, BRAF. And other category is the recommended, which is actually should do. That is RET, MET, exon 14, HER2, KRAS, and NTRK. Starting with the most common, that is the EGFR mutation. It's the most robust predictive biomarker for the response to EGFR tyrosine kinase inhibitors, and it confers a more favorable prognosis, and therefore target therapy should be placed ahead of chemo and immunotherapy in a EGFR positive NSCLC. In Asian population, lung adenocarcinoma up to 60% incidence can be seen, especially among the non-smoker females. Therefore, a great effort has been made to standardize the diagnostic test, and approximately 90% of all the EGFR mutations, they consist of either a deletion in exon 19 or a single specific point mutation, which is L858R in exon 21. So FDA has approved two kits. We are having both at our center at RGCI, the COBAS EGFR mutation test, and also the COBAS EGFR mutation test V2 for T790M, and also QIAGEN TheraScreen for EGFR PCR based technique. So these tests are highly sensitive, and they can detect mutation in the sample with tumor infiltration as low as 10% or up to 20%, as low as. But unfortunately, the resistance to tyrosine kinase inhibitors are inevitable. And the most important cause is the T790M mutation. That alone, it takes into around 40, it accounts for 40 to 55% of the cases. Besides that, EGFR point mutation or EGFR amplification, and also MET amplification accounts for 5% of the cases. And even a transformation to small cell lung cancer also accounts for 5% of the cases. So these are the various mechanisms of resistance post first line, and the most common is T790M, for which osimertinib is a drug of choice. So here comes the role of liquid biopsy. Several studies have supported the use of plasma genotyping as the first line testing to detect T790M, and the tissue biopsy would be required only when T790M is not detected in the plasma, as false negative rate of 30% is associated with plasma genotyping. So the specificity is 100%. If it is there, it is 100% authentic. But the problem is with the sensitivity that plasma genotyping can miss 25 to 30% of the cases. However, the treatment response to either a tissue or a plasma detected sensitizing mutation is the same. Hence, the specificity is 100%. The recommended and established use of the first line osimertinib recently may largely prevent the development of this T790M resistance, and also has a better CNS penetration. Coming to the ALK rearrangement, more than 12 different variants of EML, ALK variants, and non-EML fusion genes have been detected. The impact of the ALK variants on the heterogeneity of the response to the ALK inhibitor has not been fully elucidated till yet, and it is seen in 5 to 8% of the patient with advanced NSCLC, quite often seen in young and non-smokers. And these and the various studies have shown that, and this is a meta-analysis of 12 studies, they have shown the superiority of the ALK inhibitors over chemotherapy in terms of progression-free survival and objective response rate. And the next generation agents like alectinib, brigatinib yielded a better response intracranially than crizotinib in terms of both objective response rate and time to CNS progression. So coming to the method of identification, immunohistochemistry or a FISH testing is recommended if you are going for a single gene, and NGS as a part of multi-gene assay. So in FISH, what we do is that we just we take two probes. So one probe is actually tagged to the ALK gene, while the other probe is tagged just adjacent to the ALK gene. So if there is a break apart, so if there is a rearrangement, so we can see that the two probes, now the distance has increased, and that is what reflected in the fluorescent microscopy when we evaluate. So when there is a wild type, there is no rearrangement, we can see the two signals quite close and fused with each other, while when there is a rearrangement, we can see they are distant apart at least more than twice the diameter of the signals. This is the immunohistochemistry, and we can see that strong diffuse positivity amounts to positive test. Even a moderate staining with a contiguous pattern also amounts to a positive test. While testing, we have to always take a positive and a negative control. Immunohistochemistry had advantages. It is faster, cheaper. So if today I have seen the morphology, many times my medical oncologist, we consult that if it's a non-smoker female having a signet ring or a solid histology. So straight away in the evening we put ALK, and in the very next morning I'm ready with the report like ALK is positive, so that the patient can be put on the targeted therapy, which shows a very phenomenal effect very quickly. So I'd say as the advantages, it is faster, cheaper, standardization is easier, more labs can do it, even can be done at periphery. It's reliable as the normal lung tissue do not express ALK. And the recommended clone, which is FDA approved, is D5F3 from Roche. We are using it on Ventana platform, which was approved as a companion diagnostic for crizotinib. The superiority of TKI crizotinib over chemotherapy in the first line ALK positive advanced NSCLC was proven long back in 2014. However, the resistance to treatment invariably develops, often with the progression in the brain. So here comes the role of the second and third generation. The second generation alectinib, brigatinib, ceritinib, and third generation lorlatinib TKI have proven their better efficacy. The third generation lorlatinib, which led to 72% improvement in the PFS compared with crizotinib in the first line treatment. Coming to the ROS1, it is ROS1 is an oncogene one. It is a receptor tyrosine kinase. The rearrangement is seen in 1 to 2% of the NSCLC, and it is because of the translocation between the ROS gene and various other partners. The most common one is the CD74, and that leads to activation of the downstream oncogenic pathway, including the JAK-STAT, the PI3K, AKT, mTOR, and RAS-MAP kinase, MEK-ERK pathway. So the patient in which the ROS1 rearrangement is detected, they are sensitive to ROS inhibitor, crizotinib and entrectinib are FDA approved, who are treatment naive or post chemotherapy. Again, the method of detection, the FISH is recommended when you are going for a single gene assay, and NGS as a part of multi-gene assay. Immunohistochemistry here is a very effective way of a screening. It is not the diagnostic. So the clone we are using here is D4, D6 from cell signaling antibody, which is a recommended antibody, and recently 1 or 2 years back, SP384 clone from Ventana is also a recently addition recommended antibody for the screening. But the bottom line is that all positive immunohistochemistry cases must be confirmed with the FISH analysis before we are putting the patient for the targeted therapy. Unlike in ALK, where IHC confirmation is good enough, whereas the IHC positivity is good enough. So it can show various type of pattern. Like this was an unusual pattern in which the adenocarcinoma was showing a micropapillary pattern of growth, and this was the strong and diffuse ROS1 expression, which was subsequently confirmed on FISH analysis. So this was the ROS, and now coming to the BRAF mutation. So BRAF is a downstream signaling mediator of KRAS that actually activates the MAP kinase pathway, and the activating mutations are observed in 1 to 3% of NSCLC. Mutation can occur at V600 position of exon 15 or outside this domain. And NSCLC patient progressed on chemotherapy. The combination of BRAF and MEK inhibitor, that is dabrafenib and trametinib, has been approved by FDA. And the preferred testing method is the PCR sequencing when going for a single gene assay, or NGS as a part of multi-gene. So the efficacy was proved long back. So these were the initial encouraging trials that have shown that dabrafenib plus trametinib could represent a new targeted therapy with robust anti-tumor activity and a manageable safety profile in the patient with previously treated or untreated BRAF positive mutant NSCLC. So these were the must-do tests. Now coming to the recommended, that is should-do test. So starting with the most important, that is the MET exon 14 skipping mutation or amplification. So because that leads to the dysregulation of the MET pathway. So basically MET is a proto-oncogene that actually encodes tyrosine kinase receptor for hepatocyte growth factor, which is the ligand. So in this figure, you can see that if the exon 14 is skipped, like when the messenger RNA transcript is formed, here you can see that there is a exon 14 skipping, so there is no exon 14 over here. So what it leads to the formation of a truncated protein, which is the intramembranous, that is the Y1003 protein, which is a protein which is actually required to bind with the CBL, the CLB, which is for the ubiquitination proteasome degradation pathway. So when the protein is truncated, so it will not able to bind with the CLB for the ubiquitination. So what will it lead to? So here you can see that this is the ligand and the receptor. So if this normally when the Y1003 protein binds to CBL, it leads to this ubiquitination proteasome degradation pathway. So once this protein is truncated, so basically there is a lack of now regulation and degradation. So what it will lead to? It will lead to a constitutive activation of the MET pathway that will lead to cell proliferation and tumorigenesis by these various pathways. So when to anticipate? So on morphology, if we get to see a sarcomatoid carcinoma in which these are the spindles, malignant spindle cells, and the cytokeratin is positive. So on eye, and they are frequently P40/TTF1 negative. So when you have a NSCLC with a NOS or carcinosarcomatous differentiation, this morphological pattern may warrant a upfront MET gene testing. So sorry, what is the characteristic of the NSCLC with the MET exon 14 skipping mutation? So MET exon skipping mutation, they are seen in 3 to 4% of all the metastatic NSCLC. They can be associated with amplifications, copy number variants, quite often seen in females, the elderly, especially the non-smokers. And the mutation is highly predictive of response to MET inhibitors. And FDA has approved capmatinib and tepotinib for metastatic NSCLC whose tumors have MET exon 14 skipping mutation as detected by FDA approved test. And MET exon 14 is also an independent indicator for a poor prognosis for a shorter overall survival in NSCLC patient, as can be seen in these two graphs in the two studies. So the foundation one companion diagnostic is the DNA-based method for the detection of MET exon 14 in the tumor tissue. However, nowadays RNA-based sequencing is preferred over the DNA-based NGS because the RNA sequencing has the advantage of encompassing all the causal genomic events actually that leads to exon 14 skipping, hence being much more sensitive. RNA sequencing detects the fusion of exon 13 to 15, and in one study that was published in JTO 2019, approximately 60% of RNA positive results were false negative in the DNA assays. So I can explain it diagrammatically more easily. So this is a normal transcript RNA. So when exon 14 is intact, so we can, so if the n number of base pair is assigned to this from exon 13 to 15. Now what happens if there is an exon 14 is skipped, as you can see in this figure? So what will happen? So the 140 base pairs are attributed to exon 14. So the number of base pairs here will be n minus 140. So that is how it is detected with a good sensitivity with the RNA based sequencing. Now MET amplification as a mechanism of MET dysregulation is also there. So MET amplification is regarded as a primary driver gene and also one of the main mechanism of EGFR TKI's resistance. Depending upon the assay and positive cut point, the occurrence of de novo MET amplification is about 1 to 6% in lung cancer, and many studies have associated MET amplification with the overall survival. So a high amplification, that is a MET to CEP7 ratio of more than equal to 5, appears to be the strongest predictor of a true MET-driven tumor, which is seen in less than 1% of the lung adenocarcinoma. And these are the curves in the two different studies showing the MET amplification is associated with the poorer survival in the NSCLC patients. Now, MET is also as a co-driver in NSCLC. The MET amplification in EGFR mutant NSCLC comprises of 5 to 15% of the EGFR mutated tumor that have acquired resistance to TKIs who were put on initially gefitinib or erlotinib. Liquid biopsy might be a very important tool to use in this situation to detect the secondary mutations without repeat biopsy and discomfort. And now with osimertinib as a first line of choice, the spectrum and association of MET mutation will remain to be seen in near future. Coming to the HER2 mutation, so the HER2 is a EGFR family receptor tyrosine kinase, It is seen in 1 to 4% of NSCLC tumor, common in non-smoker females. Majority of these mutations are in-frame insertion in exon 20, and few cases show mutation in even in other exon. And it is detected using PCR or NGS. Early phase clinical trials suggest that the patient with the tumors harboring HER2 mutation progressed on chemotherapy may respond to trastuzumab-based regime. However, the trial demonstrated no benefit of trastuzumab for HER2 amplification. Coming to the RET rearrangements, the RET gene encodes a cell surface tyrosine kinase receptor. RET rearrangements are identified in 1 to 2% of lung adenocarcinoma. They are seen in young and never smokers. And the testing method recommended is a NGS, which is a multi-gene assay is recommended. Although break apart FISH, but it is not economically feasible because of the low incidence, the rarity of these mutations. So the FDA has approved selpercatinib and pralsetinib for the metastatic RET fusion positive NSCLC, and encouraging results were seen in the multi-cohort open label phase 1-2 Libretto 001 study. The anti-RK fusion up to 1% prevalence is seen in NSCLC, and larotrectinib and entrectinib are the two FDA-approved oral TRK inhibitors which are approved in the tissue agnostic fashion. And again, the recommended method is the NGS as a part of multi-gene assay. However, IHC, there is a clone EPR17341. We are also using it in our lab, and that is only for the screening. So diffuse and strong cytoplasmic staining, if it is there, then we can subject the patient for further confirmation by NGS or by FISH. Standalone tests are not cost-effective or feasible because the incidence is very low. The efficacy of larotrectinib has been proved in early phase clinical trials. Of the 12 patients with the lung tumors, 9 experienced a response to treatment with a response rate of 75%. NRG1 fusion, the fusion involving the neuregulin 1 gene, they are rare, and again the incidence, the prevalence is less than 1%. The recommended method again is NGS as a part of multi-gene assay. The data have suggested a poor activity of chemotherapy and immunotherapy in NRG1 fusion cancers. A case series of 5 patients who received afatinib therapy for NRG1 positive lung cancer demonstrated 4 partial radiological response in 5 patients, with 3 of these lasting over 18 months. Other targeted therapeutic against NRG fusions are in clinical trial development, such as seribantumab. Lastly, the RAS mutations, the activating KRAS mutations, which activate a number of downstream signaling pathways, are observed in approximately 25% of lung adenocarcinoma. The recommended method again is the NGS as a part of multi-gene assay. Multiple agents specifically targeting the KRAS G12C mutation, which comprises of approximately 50% of the KRAS mutation in NSCLC, have emerged. Sotorasib is approved by FDA for KRAS G12C mutated locally advanced or metastatic NSCLC who have received at least 1 prior systemic therapy. So now NGS is now preferred over a single gene assay. Why? Because it is a tissue proficient. Even a 10 nanogram input of DNA and RNA is sufficient. It is also a resource proficient. It's a one test, one experiment, one platform. And the variant allele detection cutoff is around 5%. Hence, it overcomes the problem of low tumor fraction. And it also helps in the detection of the various types of mutation, which can be categorized as tier 1, tier 2, and tier 3, so that the patient can be receiving the targeted therapy, or they can be recruited in clinical trials, depending upon the tier. And NGS can also use plasma as a sample, and FDA approval is there for the analytical clinical validity and the clinical utility. However, turnaround time is still a problem, that it takes 2 weeks at least. So coming to the biomarkers for immunotherapy, although as of now there is no a robust biomarker, but work is in progress, and these are the various options that are at our disposal, and these are the MSI, tumor mutation burden, gene expression signature, and PD-L1 immunohistochemistry. Out of all these, it is the PD-L1 IHC that has emerged with a passable utility. So these are the indications of immunotherapy in the NSCLC. For metastatic NSCLC, it can be utilized for the first line or even for the second or the later line treatment. For locally advanced stage 3 NSCLC, for the consolidation treatment. And the pembrolizumab was approved 3-4 years back as a monotherapy upfront for the NSCLC or adenocarcinoma, or even NSCLC NOS or squamous cell carcinomas, in which the PD-L1 expression is more than 50%. And these are the current standard recommendations for the immunotherapy. For the first line, pembrolizumab monotherapy if TPS is more than 50%, and in combination with chemotherapy when the TPS is less than 50%. For the second or the later line, for the pembrolizumab for TPS more than 1%, and for nivolumab for any TPS. And nivolumab in combination with ipilimumab has been approved as a first-line treatment for metastatic NSCLC expressing PD-L1 more than 1%. So PD-L1 IHC testing is an established predictive biomarker for immune checkpoint inhibitor in NSCLC. It is not a very robust biomarker, but it is still the best we have. So these are the IHC assays which we use for the NSCLC as a companion diagnostic assays. So two clones are recommended. One is the PDL1, that is the 22C3 assay from PharmaDx, DECO, and the platform has to be a DECO autostainer. So when we say a companion diagnostic, that means everything has to be as per the assay, like the same antibody, the same platform, the same reagents, everything, the sequential of the reagents, everything has to be as per the specified recommendation. And the other is the Ventana PDL1 SP263, which is done on Ventana Benchmark Ultra, which is actually CE mark, European Conformity Mark, while 22C3 is the FDA approved also. But in our experience, what we have seen is that the SP263, although Blueprint study has long back has shown that there is a good concordance, but over a period of long time, like we are reporting daily 4, 5, or at least 5, 6 cases in a day. So and we are reporting since 2017. So what we have found is that SP263 actually it is staining more tumor cells, and we have literature also now which is saying that the references are there, which is saying that SP263 has a tendency to stain more tumor cells as compared to 22C3. So participation in QAS and proficiency testing is very important nowadays. This is just a example I have shown for the PDL1. Like we are enrolled with Nordic UC immunohistochemistry control, which is based on Denmark. So it is not only just for the PDL1, for all the molecular testing. So it is very important for the participation in this external quality assurance scheme and proficiency testing. And why it is important? Because it ensures the accuracy and reproducibility of the test results, ensures the integrity and confidence of pathologists and technical staff. It also complies with the local, regional, and national regulations and lab accreditation requirements. So to conclude, there is extensive role of biomarker testing in metastatic advanced NSCLC adenocarcinoma especially. Broad molecular testing, NGS, and liquid biopsy have already made their place for the biomarker assays. Multidisciplinary communication is essential for the quality information within the required time frame, that is turnaround time, and that too at judicious cost. And it's incumbent upon pathologists to make the testing reliable by optimizing pre-analytical, analytical, and post-analytical steps. Thank you very much.
Hello. Thank you, sir, for a very nice presentation and very lucid description of how should we go about doing our molecular testing in NSCLC. So there are few questions in my mind, and I would want to ask you these questions. We as clinicians get a lot of requests from a lot of companies for us to be prescribing their NGS. So as a clinician, are there any so-called points that we can see to find out which NGS is a better NGS compared to the other any other NGS from any other laboratory? So we have the hotspot NGS, we have comprehensive NGS now. So we have a DNA-based sequencing of NGS, RNA plus DNA both also, and that also is important, like you said in your talk. So any thoughts?
Yeah. So we have. Yeah. So we have. Am I audible?
Yes, sir. Yes.
Okay, so we have actually recently, it's almost now 1 year that we have made a NGS Smart Lung panel that cost at around 30,000. And what we do is that this is a code that we have made, and we are doing NGS with EGFR by PCR and ELK by IHC.
Mm-hmm.
And in this NGS, we have the various genes which are analyzed for the single nucleotide variation and genes analyzed for the rearrangements. So that takes into account roughly 30 genes. And this is not a very comprehensive panel, but considering the cost, it's a very a good panel, like if the cost is the issue.
Yeah. So sir, this has both the DNA and the RNA based sequencing, like you said that RNA.
Yes. So the gene analyzed for the single nucleotide variant, like AKT, ALK, BRAF, EGFR, even KEAP1, STK11, TP53, RB1. So they are all DNA based, while the RNA based comprises of these AKT, ALK, BRAF again, and ERB2, MET, RET,
Right.
and all these.
Right. And so we should be choosing an NGS which has got both DNA and RNA based methodology of sequencing, isn't it?
Yes, definitely.
So that is one. The other is that what are your thoughts on the liquid EGFR method of testing, where the report comes in a day or two, and I'm talking about the upfront EGFR testing, not the T790M.
See, for the upfront EGFR testing, but see, you have to understand that for this, actually, the tissue diagnosis has to be there at least.
Yes, agree. After a tissue diagnosis is done, so if you're talking about the liquid EGFR estimation, just because the turnaround time is within days, very initial days, so can this be done, and is it validated by USFDA?
So I'm not sure about the validation for the treatment decision making, but yes, if the histological diagnosis is there, and if there is a the liquid biopsy is showing the EGFR mutation, so patient can be put on a therapy.
Okay, right, sir. And sir, yeah, your last thoughts on the KEAP1 mutation, how much of that you've seen, and what has been the outcome of those patients? We know that these are poor prognostic factors. So do you really advocate that we should now that we know about KEAP1 mutation, we should always do it in our practice so that we can prognosticate our patients?
Yes, it is recommended, because the patient who are having KEAP1 or STK11, as far as I have read, these patients are the one who do not respond well to immunotherapy also, and besides being a poor prognostic factors.
And very poorly to chemotherapy as well.
Yes.
Right, sir. Thank you so much for the enlightening talk, and we always get enriched once we listen to your presentations. Thank you so much.
Thanks a lot, Dr. Rajan.
Thank you. So after this very nice presentation by Dr. Pasricha, we move on to the next talk of the session, which is on the use of osimertinib in the adjuvant setting in resected EGFR mutated stage 1B and 3A non-small cell lung cancer. And to talk about this, we have with us Dr. Chandra Gowda, sir. Sir, good evening. He is the Director of Medical Oncology at BLK Hospital. Sir, over to you.
Thank you, Rajat. Thank you, Esther, for the opportunity. So let me share my screen. Right. So everyone can see the presentation, right?
Yes, sir. Yes.
Okay. Sorry. Right. So I've been given a task to present the adjuvant osimertinib as an adjuvant therapy in patients with resected EGFR mutant stage 1B to 3A NSCLC. That is updated results from ADAURA trial. So this is a phase 3 trial, phase 3 randomized trial in patients who have been completely resected stage 1B, 2 and 3A NSCLC. So when at the time of enrollment, it was an AJCC7 which was followed. So that's more than 3 centimeter lesion. So in all patients, this was conducted in Japan and Taiwan, and it is with a good performance status, more than 18 years, and a limited set of non-squamous NSCLC in exon 19 and L858R mutations. These selected mutations are very, very common, as was elucidated by Dr. Sunil. An excellent talk. So only those 2 mutations have been included. And pre-op, post-op, the brain imaging was conducted before, and then they found to be having without any brain metastasis. And the time interval between of starting the osimertinib is within 10 weeks of using adjuvant chemotherapy, or 26 of patients with adjuvant chemo. So without adjuvant, it's 10 weeks. With adjuvant, it should be more within 26 weeks. So they were stratified as for the stage and the type of the EGFR mutation in the race. And they're randomized between osimertinib 80 mg versus placebo. And the primary endpoint of the study was disease-free survival by investigator assessment in stage 2 and 3A study, stage 2 and 3A. And that was designed for superiority under the assumed DFS of 0.7. The key secondary endpoints were a DFS in overall population, including stage 1, and the DFS at 2, 3, 4, and 5 years. The OS, safety, and health-related quality of life. There were pre-specified exploratory endpoints, that is, patterns of recurrence, time of CNS recurrence, or a death. So they were also in the endpoint. You can see the DFS benefit. So there was an interim analysis, though the FDA called in for an interim analysis simply because of these curves. So at 1 year, you can see there is a significant separation of the curves between the placebo and osimertinib. So the 61% was a 97%, and initial the hazard was seen, which was 0.17. It means that almost 83% of the patients who have been benefited by using osimertinib in the adjuvant setting. So that benefit was seen consistent between in the second and the third year. So it is beat a stage 2 or 3A, and in patients if we include a stage 1, the benefit increases. So I'll probably dwell upon it in the subsequent last slides, the details of it. These were the baseline characteristics in the overall population between osimertinib and the placebo. So all were well matched. If you can see the AJCC classification, 7th edition and 8th edition. So each stage 1B, 2, 3, 1B, 2A, and 3A patients, almost 30, comprising equally of 30% each. So they were well balanced. So definitely there was adenocarcinoma histology, and EGFR mutation between the DEL19 versus L858, the 55 versus 45. So I just want to point out the adjuvant chemotherapy patients who have received adjuvant chemotherapy and who have not received. So it's 60-40. So almost 40% of each arm did not receive chemotherapy. That's an interesting point while analyzing the results. So when you come to a primary endpoint, that's a DFS, which again I have put it up. So there is an advantage of disease-free survival. At 3 years, we can see the osimertinib has 65.8 months versus placebo, which was 21.8 with hazard of 0.23. So that's a really significant advantage of using osimertinib in the adjuvant setting. So if you can see in a patient who have in an overall population, so I just want to go back and say that at 3 years, it's a 70 versus 29% of using osimertinib, favoring osimertinib. But you can see after that, the curve is falling rapidly down. It means after 3 years, you can see in at least stage 2 and stage 3 that this disease is coming back. That just questions us: do you have to do some sort of a MRD to have a benefit, to give an extended benefit of osimertinib? That's the first question that needs to be asked. Or what is an actual duration of osimertinib, especially in stage 2 and stage 3A disease? So these are the questions which needs to be asked. And we also have to wait for the overall survival advantage. Nevertheless, DFS is definitely alarmingly so good that we probably definitely tend to use it. That's what the importance of curve coming down in stage 2 and stage 3. However, in stage 1 disease, as these are the good prognostic category, so they stay. A lot of these patients would almost be cured in using an osimertinib. So if you can see the updated DFS across all the subgroup in the overall population, so all patients, irrespective of the overall the sex, the smoking history, race, any stage, or any of these two EGFR mutations, whether they received chemotherapy or not, they have been benefited by the osimertinib. So this is an updated DFS by stage. As I said, the stage 1, definitely the curve is flattening out, indicating a lot of these patients have a cure. However, in stage 2 and stage 3, the curve is coming down after 3 years, indicating that we need to understand more in this particular scenario. So this is as per the 8th edition, reiterating the fact which I was already I've told. And this is a pattern of disease recurrence in our overall population, including this stage. The most first site of recurrence were the lung, so it's 12%, the lymph nodes, that's 6%, and the CNS in 6%. So we also see the CNS recurrence in patients who have received osimertinib. As I said, these are the things which we need to study, whether we need an extended benefit. As patients who are receiving the osimertinib, the CNS recurrence is comparatively lesser compared to placebo. So do they need extended benefit? And MRD, all those play a role in this particular scenario. So it also includes that there's a lung recurrence as well as a lymph nodal recurrence. So that also points us towards giving a radiation to a particular subset of these patients. So all the stage 3 patients, how many of them have received a radiation and then going ahead with osimertinib? So all those factors have to be sorted out. So this is again patients updated CNS disease-free survival in patients stage 2 and 3, as I was talking about. Definitely osimertinib has resulted in better benefit. So only 3 or 14% of patients had CNS recurrence in osimertinib compared to 71% with the placebo. So this is condition probability of CNS and the non-CNS recurrence in patients with stage 2 and stage 3. If you can see here the curves, the estimated probability of observing CNS recurrence in the absence of non-CNS recurrence or death at around 36 at 3 years is 2% with osimertinib versus 13% with the placebo. So this is again indicating the same, the estimated probability of observing CNS recurrence in the overall population as in osimertinib it is a bit lesser compared to the placebo. So the safety analysis, as all of us who have used it, it is a well-tolerated drug compared to the other TKIs, the first generation, second generation TKIs. So it is better tolerated, but nevertheless, we also see some of the GI side effects, mainly comprising of diarrhea and some skin toxicities that was seen with osimertinib. What is more interesting is some of the patients, with 3% of patients may have an interstitial lung disease that needs to be observed, and QTc prolongation. So these are the two things that you need to monitor and observe. The rest all can be they usually well tolerated and can be managed. So to conclude, in this updated disease-free survival analysis of osimertinib versus placebo, patients have been followed for further 2 months, so it's total 3 years. The overall, there was 77% reduction in the risk of disease recurrence or death with adjuvant osimertinib versus placebo. The median DFS was 65.8 months in the OC versus 21.9 in the placebo. There was also in an overall population, also it was including stage 1, and there was consistent benefit of the osimertinib. An improvement in the DFS was regardless of whether the patient has prior adjuvant chemo or not. The DFS benefit was across all stages and was consistent following restaging based on the 8th edition as well. So this osimertinib has demonstrated a clinically meaningful improvement in the CNS DFS as well. So the safety profile was consistent with the established safety profile of osimertinib as per the other trials. So these updated data reinforce that the adjuvant osimertinib as a standard of care for patients with EGFR mutant stage 1B to 3A NSCLC after complete tumor resection with or without adjuvant chemotherapy. Thank you very much.
Thank you, sir, for this presentation on adjuvant osimertinib. So, sir, there are a few points now coming up with this update which has come for the ADAURA study. We see that the DFS is quite impressive, in excess of 5 years, and I think as a clinician we find this quite reassuring. And there was a doubt regarding whether we should, I mean, I should not say it, any doubt, but then we'd seen there is less benefit in patients who are having a stage of 1B. So in your clinical practice, do you offer these to your 1B patients also? That is question number 1. And number 2 is that there is an ongoing study now, which is the target study, where it is looking at the use of osimertinib for 5 years now. And the reason for that is that when the curves have separated, it has been seen that all the disease, the recurrences have happened post 3 years. So, they want to see whether use it for 5 years and further improve on the hazard ratio, which already is quite surprising impressive for us. What is your take on that?
First question, the stage 1B, even stage 1B, you can see the hazard of 0.23 in an overall population, but stage 1B it's definitely lesser. But this definitely I will be inclined to use, as some of the patients would end up in cure. So that's what I want to point out. So in stage 1B, we are achieving a cure, some MRD negativity. I think the MRD is one which probably will give us a clue in the later lines where else we should do it. But it's still till that is available, I would still use even 1B. The second question, as was pointing out, as rightly pointed out, after 3 years the curves are coming down. So that's where I heard the original speaker talking about the MRD status as well as the extended osimertinib to extend this, but to make it the curve flatter. So I think the target will answer that, and definitely that will be interesting to see.
Right, and also the two other interesting studies ongoing in this space are ADAURA 2, where they're looking at 1A2 and 1A3 also. So they want to extend the benefit to the very initial stage patients also. And I'm sure the LAURA study, where post CTRT also EGFR mutated patients, they are trying to give osimertinib. So because we do know that from the Pacific study that durvalumab doesn't work very well in the EGFR mutant. So I think that we still are in for more surprises in this, and of course it is beneficial for our patients, and we would love to have that. So thank you so much, sir. We always are happy to listen to your talk. Thank you.
Thank you very much.
So after this interesting discussion on the use of osimertinib, we go to the next topic, which is the molecular profiling of lung cancer for targeted therapies. And to discuss this, we have with us Dr. Nagendra Sharma, who is a dear friend. He is a principal consultant at Max Saket Hospital. Dr. Nagendra, welcome. Good evening. Over to you.
Thank you, Dr. Rayat. Can I start my slides here, if possible?
Yes, sir, you can start.
Okay, then. I think my slides are visible and my voice is clearly audible, right?
Yes, it is.
Perfect. So the title of this presentation is Molecular Profiling of Lung Cancer for Targeted Therapies. So where are we in 2023? So how molecular oncology have evolved over the last couple of years? So we know that getting advanced cancer diagnosis is not only devastating for the patient, it's actually devastating for the entire family. The challenges which these patients face, they are not only physical, they are emotional, they are spiritual, they are psychological, and above all, they are financial. If I state that we are living in the era of, or golden era of advanced lung cancer treatment, I don't think it's in an overstatement. So where are we? So most important thing which I will be highlighting today is that biomarker-based therapeutics approaches in lung cancer. What is the clinical value of comprehensive genomic profiling, CGP, in the lung cancer? Clinical value of liquid biopsies in lung cancer, and case-based discussion of rare and common alterations with how a case or interesting case have unfolded. I'll be discussing at last. So lung cancer, we know, is the leading cause of cancer death worldwide, and only a small proportion of NSCLCs patients are diagnosed at an early stage, that is stage 1 and stage 2 put together, when the tumor can be treated by surgical section. For both sexes combined, lung cancer is the most commonly diagnosed cancer, and there is a declines in the smoking and improvement in the early detection and treatment, and have resulted in continuous decline in the cancer mortality rate since its peak in 1991. Globally, 2018, there were an estimate of 2.1 million cases and 1.8 million deaths from lung cancer itself. And projected cost of lung cancer treatment in 2020 is above $15 billion. Lung cancer caused more death in 2017 than breast cancer, prostate cancer, brain cancer, and colorectal cancer combined. So declines in the lung cancer mortality have accelerated in the past decade, and suffering the largest ever single year drop in overall cancer mortality by 2.2% from 2016 to 2017. By and large, what I meant to convey is there is unmet need to increase the longevity of this life of these patients. We have to keep these patients as good as possible for as long as possible. Our understanding of genomic landscapes of lung cancer is continuously going. It started in 2004 when we are having a pie chart in which KRAS, EGFR were the mutations, and largely we don't know what is happening to the other set of patients. 2014, when 10 years or 1 decade later, we know that there are so many mutations, or we call it, there are so many receptors which can pick up, like EGFR, ALK, ROS1, PD-L1, MET, PIK3CA, BRAF, KRAS, and only 35% of the cancers are non-driver related, or there's no driver related. In 2017, or 3 years, that the pie chart have opened even further. Now we are having fusions, right? We are having a CDKNA2A loss. We are having RET fusions. We are MET amplifications. We are having so many BRAF, non-BRAF mutations. So, and we are still have not reached to the maximum level. I should say that we want to know more and more about less and less, so that everything we know about nothing. This is where we are heading as far as advanced NSCLC is concerned at a molecular level. So there are plethora of options as far as target treatments are concerned. So previously it's all started with the first generation TKI. We are having only olverembatinib. For many years it used to be treatment. Over a period of time we are having, like, there are so many options right now: first generation, second generation, third generation, then combination with chemotherapy and all, and so on and so forth. For uncommon mutations also, now we are having amivantamab and mobocertinib for exon 20 insertion mutations. For KRAS, sotorasib is there. For ROS1 also, it started with ceritinib, crizotinib, entrectinib, right? Subsequent therapy, lorlatinib, entrectinib is there. For BRAF also, we know for B600D mutation, we are having darovasertib, and we can use so many other drugs for so many mutations. So I don't want to enumerate them. We all know all these drugs. So biomarkers likely to have approved target therapies for non-small cell lung cancer. It's for past so many years, we have seen that there is a improvement in precision oncology, by which we can the number of the mutation which we are detecting is increasing. So many times, if we are not doing the test properly, the molecular test, we are actually harming the patient. Why I'm telling this is because we are denying the potentially effective treatment to these patients. They have to take chemotherapies. They have to, secondary cause of treatment is more. So until as we do the proper molecular test in a proper way, in correct clinical setting, then only we will be able to figure it out. What are the uncommon mutations, co-occurring mutations, and what is the treatment for that, right? The added clinical value in using comprehensive genomic profiling for further treatment of lung cancer. So most important thing why I want to highlight it is comprehensive genomic profiling is must. Why? It identifies EGFR mutation in lung cancer patients that were missed by a standard care of testing. As we have listened to previous speakers, that we can do family testing, we can do comprehensive genomic profiling. But look at this slide. 400 patients of NSCLC cases with EGFR exon 19 deletions identified by comprehensive genomic profiling. 77 out of 400 cases with previously testing results were available, and 22% of cases were tested false negative for EGFR mutations in previous non-hybrid capture-based testing. In a subset of patients with available clinical outcomes of the information, a robust benefit of treatment with EGFR inhibitors were observed. 482 patients of NSCLC cases with EGFR point mutations identified by CGP. 1 or 3 cases with previous testing results were available. 21% of the cases were tested false negative for EGFR in previous standard of care testing, and in cases with available clinical data, benefit from EGFR inhibitor therapies were observed. CGP, that's comprehensive genomic profiling, identifies EGFR activating mutations in over 20% of patients who previously tested negative by standard of care EGFR mutation testing. That means 1 out of 5 patients will be missing if we are not doing comprehensive genomic profiling upfront. Many patients could experience improved clinical outcomes when CGP is used to inform therapeutic decision. So this number is humongous when we are dealing with a population of 1.35 billion, right? CGP identifies ALK rearrangements in NSCLC unrelated by other testing approaches. So 1070 patients samples were profiled using CGP, and 47 cases were found to harbor ALK rearrangement. 31 of the cases had previous FISH results available. 9 out of 11 patients received ALK inhibitor crizotinib. 35% of the cases, that 11 out of 31, were tested false negative by ALK rearrangement using FISH, but were detected subsequently with CGP. 78% of the treated patients, that is 7 out of 9, had confirmed responses. This number is humongous. 35% means what? 35%, 1 out of 3, you can miss, even if you are doing FISH for ALK. IHC and CGP can complement each other. This is what is the key highlight of the slide. And standard molecular tests such as IHC, FISH, and CGP complement each other effectively. Immunohistochemistry is important for accurate diagnosis and determination of subtype in lung cancer. as well as for assessing the expression of the specific predictive protein markers such as PD-L1. However, utilization of CGP can detect several markers and genomics in nature at once, avoid tissue extraction, and saves time. ISC and CGP are both important tools in the management of lung cancer and may be used complementarily. This is what we have to highlight. What is the clinical value of liquid biopsy in NSCLC? So liquid biopsy versus tissue biopsy, this debate is for past many years now. We have listened to multiple platforms. The tissue-based genomic profiling remains standard of care with advantages such as higher sensitivity for the certain types of alterations, but suffer from limitation impacting patient care. Solid biopsies can be difficult or pose a high risk, may not capture tumor heterogeneity, and tissue samples may be insufficient, inadequate, or exhaustive. This is what the technical challenge with many times pathologists will call us and they will bring us back that tissue is not sufficient, sir. Patient care plans may suffer if timely testing is not available, leading to reduced therapy options with potential for higher adverse events. This we have seen many times in our clinical practice. However, liquid-based genomic profiling may overcome some of these limitations. To name few, it carries low cost and ease of collection. Just have to take a blood sample. May capture tumor heterogeneity. That's a very important point. Robust and highly specific and intensively validated tests are available. Monitoring disease progression and recurrence is very, very easy and enables timely personalized treatment decisions by shortening time to results. So turnaround time is very, very small as compared to the solid tissue biopsies. So low tumor burden limits the capacity to detect early stage NSCLC, right? And if you see a number of patient of 5 years survival of stage 1 is hovers around 68 to 92%, stage 2 around 53 to 60%, stage 3 goes down to 13 to 36%, and stage 4 we all know less than 10%, right? So there is an abundance of circulating tumor DNA in NSCLC. As you can see, in T3 stage, the mutant allele frequency is 1.4%. T1C, it drops down to 0.1%, and T1B, it is 0.008. The nodule diameter in T3 is by and large 5, or just to take example, 5.8 centimeter. For T1C, it is 2.6 and 1.2 centimeter for T1B. So volume also decreases. The early detection of small NSCLC less than 2 centimeter or T1A to T1B lesions using circulating DNA will be limited by technical and physical constraints of detecting mutations present at a low mutant allele frequency of less than 0.1%. So this is the reason why low tumor burden limits the capacity to detect early stage NSCLC. So there's a BFAST screening trial that is a prospective clinical utility, the blood first assay screening trial. Foundation One liquid CDX showed a prospective clinical utility in the global registration trial for patients with newly diagnosed metastatic NSCLC without the need of a tissue biopsy. So in this 2,200 odd patients received liquid biopsy testing Foundation One and 5.4% of the frequency of bulk fusions in BFAST with Foundation Medicine testing, and 5% historically published frequency of bulk fusions using tissue-based testing. So what we have found out is 78% PFS at 12 months, comparable to 68% PFS for patients selected for ALK positive using tissue-based IC testing, and 87% objective response rate comparable to 83% objective response rate for patients selected for ALK positive using IC-based studies. So at 12 months, 78.4% of patients are progression-free, right? This is what the key highlight of this trial. So prevalence of genomic alteration in the first line setting for liquid versus tissue biopsy is similar. So BFAST trial, as you can see clearly, 5,800 odd patients were screened with Foundation ACT, and the selection eligibility criteria was age greater than 8 years, unresectable stage 3B, stage 4 NSCLC, measurable disease, treatment naive with good performance status, blood sent to FMI for circulating tumor DNA testing, and they picked up ALK, RAT, blood tumor mutation burden, ROS1, and the drugs were started accordingly based on this. So majority of patients have got a very good response. Liquid biopsies have the potential to measure the success of therapeutic, allowing to adjust them accordingly. So we know that the PFS is significantly longer in NSCLC patients with early circulating tumor DNA decrease or clearance, suggesting a potential role for circulating tumor DNA and GS analysis to detect pharmacodynamic biomarker of response or resistance to therapies. So there is a clearance of EGFR circulating DNA after 60 days of therapy correlated with the substantial improvement in PFS and OS. As you can see clearly in this Kaplan-Meier curve, there is a rapid decrease of circulating DNA correlated with clinical benefit, while increase correlated with progressive disease. So, case study on the use of CGP to rate both common and rare driver alteration. I'll be just discussing one interesting case. So, which I was a part of this case. So 42-year-old female with comorbidities of hyperthyroidism and migraine with no significant family history of malignancy, evaluated for the complaints of generalized tonic-clonic seizure, which was on and off for past 7 days. So, patient have consulted a neurologist upfront, and contrast enhanced MRI brain was done in March 2017, so nearly 5 years back. So, multiple metastatic lesions in parietal cerebral hemisphere were there, the right thalamus and right cerebellum. The largest was in left parietal lobe, measuring 2.7 to 2.5 centimeters in Tmax. So, medical oncologist was called because these were suspicious brain lesions. So, immediately I was on duty and I immediately advised a whole body PET CT contrast. And PET scanner picked up that patient is having a FDG-avid right lung mass in upper lobe. The Tmax of that was 5.5 into 5 centimeter, suggestive of primary mitotic etiology. Patient was also having FDG-avid brain lesions, bilateral pulmonary nodules, and mediastinal right hilar lymph nodes, suggestive of a metastatic disease. Right? As you can see clearly in this picture, there is a right lung mass of 5.5 centimeter, suggestive of a primary mitotic etiology, and then multiple brain lesions and mediastinal nodes. So, diagnostic workup was done. Right lung biopsy suggested, and the report came out to be NSCLC favoring adenocarcinoma. ICY CT1 is positive and P40 was negative. And we did the molecular testing. EGFR was exon 19 positive. We had done the fragmented test at that point of time. ALK IHC was negative, ROS IHC was negative, PD-L1 TPS was 0%. This is 2017, right? Patient was in good performance status. So the diagnosis of metastatic NSCLC adenocarcinoma, 7th ACC, it was stage 4, M1B, multiple brain lesions were there with bilateral pulmonary nodules. 8th ACC, it will be stage 4B or M1C, EGFR exon 19 deletion positive, ALK negative, ROS1 negative, PD-L1 0%. This is just a point that there is no M1C in 7th ACC and there is no stage 4C in 8th ACC, as you can see clearly in this picture. So treatment was initiated in March 2017 after discussing this case in multidisciplinary tumor board. So as the patients presented with the secondary site symptoms first, so SBRT to the brain lesions was contemplated and 35 gray was given in fractions till March 2017. After which, as the report unfolded, the patient is an EGFR mutant and a CLC adeno. So we started first generation TKI or erlotinib, 150 milligram. One can counter argue that why you have not started osimertinib. Just to highlight that in New England Journal of Medicine, this FLORA trial was published in January 11, 2018. This is a little bit later, right? Osimertinib came a little bit later. So we started first generation TKI at that point of time. And October 2017, that is after 8 months of first generation TKI, patient was having a progressive disease. There was an interval increase in the size of multiple ring enhancing lesions in the brain associated with perilesional edema, and there was an interval decrease in the size of the lesions in the lung, suggestive of residual primary pathology. So what should be the next step? Right? So we have given first generation TKI, but patient have progressed. The disease has outsmarted the treatment. The options in front of us are, we can use chemotherapy, immunotherapy, molecular profiling have to be done like solid or liquid biopsies. And if we are able to figure it out, the patient is getting EGFR T790 mutation, we can opt for the different drugs, right? I just remember that this patient was diagnosed in 2017, right? So follow-up diagnostic treatment was done and we have gone ahead with the liquid biopsy. The liquid biopsy came out to be that patient is getting an EGFR T790 mutation. And 22 copies per ml of plasma was there. And as you can see, this was in October 2017, we got this report. And there is a high sensitivity to osimertinib. And we started osimertinib, 80 milligram once a day in December 2017. Patient took it for 18 months and till July 2019. The tolerance was okay, except the grade 2 rash and grade 1 diarrhea, which was managed effectively. So patient have taken 8 months of first generation TKI and patient have taken 18 months of third generation TKI. And then this was the picture in between the PET scan, the lesions have disappeared. So July 2019, a right hilar FNA cell block was done, which is suggestive of a metastatic carcinoma. PD-L1 was DECO again done, it was 0%. So it's a clear-cut case of post-osimertinib progression, right? Patient have failed first generation TKI, patient have failed third generation TKI. What next? We can go over chemotherapy, immunotherapy, again can do genomic profiling, or again we can biopsy from the appropriate site and take call accordingly. We have done biopsy from the progressive site, and that tissue we have sent for foundational NGS. This is what we have got. Patient was having a BRAF AGK BRAF fusion. 3 mutation per megabase as far as TMB, and microsatellite was stable, and the patient was also having EGFR exon 19 deletion, which was earlier present, CDK12 and CTNNB1, right? The therapy is with clinical benefit because this is not a standard BRAF B690 mutation. So this is a BRAF fusion, which we have got post-osimertinib progression. The therapy is with clinical benefit, as you can see clearly, it's trametinib. There are other therapies with clinical benefit like binimetinib, cobimetinib, regorafenib, sorafenib. So we have discussed this with the molecular oncologist, and what we have done is, this is what the by and large picture. These are the options which we are having: trametinib, afatinib, osimertinib, erlotinib, geftinib, and degmantinib. So osimertinib alone is already exhausted. We can use either of these options based on these mutations post osimertinib. So we have digged in literature, and we have found out that BRAF V600E mutation is associated with aggressive tumor, worsening prognosis, short DFS, and shorter OS. But this patient is not BRAF V600E. This is a BRAF fusion. So BRAF fusion is a rare yet potentially actionable resistance mechanism in patients treated with EGFR TKI. How do we treat this NSCLC that became resistant to EGFR TKI through BRAF fusion? So do RAF inhibitor work, or which type of RAF inhibitor works the best? These are the questions which are standing on the table in front of us, right? So this is one report we got, that BRAF fusion is another mechanism of acquired resistance to EGFR tyrosine kinase inhibitor. So the way we are using in melanoma, we can try it, or we can because we know that the RAF proteins are serine threonine kinase that mediate the signal from RAS to downstream MEK ERK. Among the 3 BRAF, that RAF1, BRAF, and CRAF, BRAF is the most frequently altered NSCLC as a driver gene. Although the combination of dabrafenib and trametinib is for BRAF V600E is the only treatment for approved by health authorities. But in these patients in which we are having BRAF fusion, we can try other options like dabrafenib or trametinib. But dabrafenib and trametinib are approved for treatment for BRAF V600E. However, this patient combination is unlikely to work for BRAF fusion because dabrafenib is specific for BRAF V600E only. So clinical experience treating tumors with BRAF fusion has limited evidence or limited use. So response to trametinib, which is a MEK inhibitor, have been reported in melanomas that harbors RAF and BRAF fusions. So we have tried for trametinib, and it was a therapy with clinical benefit. So we thought it will work. So we started in October 2019 trametinib single agent without dabrafenib 2 mg OD for 4 months. But patient again progressed in February 2020. By and large, what I'm going to convey: the first generation TKI was erlotinib, second generation TKI osimertinib. Erlotinib was taken for 8 months, osimertinib was for 18 months. So 26 months are already over. Again, trametinib, we are given for 4 months. 30 months are already over on TKIs only. We are not given any chemotherapy or immunotherapy. Now, question is still standing: patient is having a good performance status, but disease is progressive. What to do next? Again, we tried for liquid biopsy, but this time foundation 1 NGS was non-contributory. There was no actionable mutation by and large, as you can see clearly in this report. Again, we are stuck. What next? Here are the 3 options: continue TKI beyond progression at higher dose, oral first generation and second generation TKI can be rechallenged, or go to the last, that is palliative chemotherapy. So MTAP-LOS sensitizes cells to pemetrexed. Started on doublet pemetrexed and carboplatin AUC5 2-3 weekly, 3 cycles, partial response, 6 cycle, stable response radiologically. Started on pemetrexed maintenance 3 weekly. By September 2020, patient have completed 2 cycles of pemetrexed maintenance, and the reassessment scan has shown a progressive disease. Most important thing I want to highlight here is that patient have crossed 42 months, was still alive for so many years, and still hopeful. So the law of oncology says in advanced malignancy that keep the patient as good as possible for as long as possible within limitation of science, and treatment cannot be considered as treatment until unless it's beneficial to the patient. Right? So this is an interesting case. I thought I have managed this patient, and 42 months patient was on only TKIs just by using the correct molecular knowledge we have this patient, right? So at last, I want to tell you that we have given chemotherapy, later on we have given immunotherapy also, and patient have done so well. So, and last, the take-home message was, which I want to convey is that if it were not for greater variability among the individuals, medicine or medical oncology might as well be a science, not an art. And he who studies medicine without books sails an uncharted sea, but he who studies medicine or medical oncology without patients doesn't go to sea at all. This is told by William Osler so many years back. It holds ground even now. I think I've done justice to the topic given to me. Thank you very much for giving me the opportunity to be part of this scientific quiz. Over to the organizers, please. Thank you.
Thank you, Dr. Nagendra. This was a very interesting case that you presented, and a very typical example of how our patients, they benefit from the use of foundation one, be it the solid foundation or the liquid foundation. So I'm sure if cost is not an issue, one would like to do a foundation in almost all the patients where we come at crossroads many a times, when while treating we don't know what should be the good way ahead, and there is no standard of care option. Do you agree?
Right, sir. So by and large, what we are trying to do is we want to know more and more about less and less, so that we know everything about nothing. This is where the precision oncology or molecular oncology is going, right? So I think we should be optimistic, and we should try to do the standard oncological molecular test. Then only we will be able to figure it out at molecular level what is going wrong, and we can give the correct treatment on the patient's merit.
Right. And also a molecular oncologist should now be there as a part of our discussion in the tumor board also. It is time to really have these people also on board, so that we can understand these reports in a much better way, and also pass on that benefit to our patients. And Roche, for one, actually does that. They provide us with a help from the molecular oncologist also. So it becomes quite reassuring in that sense also.
Absolutely right, sir. Absolutely right. I do agree.
Right. And are you doing foundation in other solid malignancies also? Like, of course, lung is probably the poster boy of molecular oncology, but other GI malignancies where we don't have any standard of care options, there also you're resorting to foundation.
Right. Absolutely right, sir. Because we know that there are mutations, or we are going towards tumor agnostics. So many times, patient, if they are not affordable, we always document in our reports. We always we are proponent of that. We are advocate of that. And if the patients are not able to afford, then we'll tell them that we advised, but patient or having logistic issues, possible, we'll try to encourage patients to undergo this comprehensive genomic profiling wherever possible. If we cannot do it upfront, later on when the patient progresses. So I want to give an example, because you have asked a very apt question. In gallbladder cancer, I got ALK1 mutation positive, right? In colon cancer, I got a BRCA mutation. So there are so many things which are happening at molecular level. Until unless we'll tell them or we'll search for that, we'll never find out, right?
Yeah.
So we always encourage patients, especially when the patient have exhausted 2 or 3 lines of treatment and patient have lost the merit, the performance status have deteriorated. Their options of oral drugs are there through molecular testing, right?
Right. I had a patient of gallbladder where nothing was working. It was primary refractory to GemCis, and I told them for NGS testing. They were not affording for foundation, but they somehow got one of the NGS done, and it was PIK3 mutation. So I had nothing to give. I gave alpelisib, and the next PET scan was metabolic complete response. So that's how it is. So yeah, I completely.
Right. And one more thing I just want to highlight to this platform, that until we do comprehensive genomic profiling, we will miss co-occurring mutations. That also is coming now, right?
Yes.
Many times when we are doing fragmented testing, we are doing EGFR, ALK, ROS1, if they're negative, and other tests we'll do. But when we are doing comprehensive genomic profiling, many times we'll get 2 mutations, because in literature we know that all these mutations are mutually exclusive. When we do comprehensive profiling, we have seen I've got 3 patients in which I got EGFR plus ALK, EGFR plus BRAF, EGFR plus ROS1, and the patient in which ROS1 was the driver mutation, not EGFR, right? Yes. So we're given 6 days of crizotinib, and one on Sunday, I'm giving osimertinib. After 4 months, PET scan is clean. Can you imagine this? So this is what is oncology is moving towards. So we have to dig deeper Right.
Yeah, right. Thank you so much for a very nice presentation, very interesting discussion. So now we move ahead, and the next topic is going to be on redefining the management of early lung cancer, and what is the role of the use of atezolizumab in early lung cancer now is what we are going to discuss. So this topic is going to be taken by me. Next slide, please. So we know that atezolizumab is approved in non-small cell lung cancer, and the initial approvals all have been in the metastatic setting. And this is the slide to tell us that the second line approval in metastatic NSCLC was according to the OAK study. And after that, there are 3 studies in the first line. Be it the IMpower 150, where atezo plus bev plus paclitaxel is the treatment that we know is the approved treatment regimen in the upfront setting in patients of metastatic NSCLC. Then we have the IMpower 130, where in the non-squamous histology there is approval of using atezolizumab with the standard of care chemotherapy. And we have in the first line setting the IMpower 110 study as well. There also there is an approval. This is in patients who are having a high PD-L1 status. But now we're talking also about IMpower 010, which is the study in the early non-small cell lung cancer, and we've got the approval for atezolizumab in this setting as well. We'll be talking about more in the subsequent slides. Next slide, please. So first of all, just talking a bit about what we already know in the metastatic setting is the IMpower 110 study. Like I said, that 110, 130, and 150, all 3 of them, they are approvals that we have the use of atezolizumab in the first line. IMpower 110, non-squamous and squamous histology both, and atezo was compared to the standard of care chemotherapy, and atezo monotherapy was found to be better in the biomarker selected population of high PD-L1 expression, immune cell scoring of more than equal to 50%. If you talk about the IMpower 130, it was only in the non-squamous histology, and IMpower 150 again in the non-squamous histology, where atezo in 130 was compared, atezo plus chemo was compared with only chemotherapy, and it was found to be better, the atezo arm. If you talk about 150, again the atezo plus bev plus paclitaxel carboplatin arm was found to be better than only chemotherapy. Next slide, please. Just talking about IMpower 110 in the next few slides. Next slide. Like I said, that it is in squamous and non-squamous histology both. And this was a trial design of the study where stage 4 patients in PD-L1 selected population, EGFR and ALK of course being negative, and chemotherapy naive patients, they were randomized 1:1 to receive atezo monotherapy in the standard dose or chemotherapy in the standard doses according to the histology. And the primary endpoint was overall survival in the complete population, and it was excluding the patients who had EGFR and ALK mutation. And the key secondary endpoints were PFS, overall response rates, and duration of response. Next slide. So it had a hierarchical statistical design, and the OS was tested as a strategy, which was that the primary endpoint of OS in the TC3 or the IC3, that is the high PD-L1 expression, was tested, and this was a subgroup which was met. So the OS testing boundary in the TC2/3 or the IC2/3 population subgroup population was not crossed. Next slide. So we'll be sticking our discussion to patients who had a TC3 or a IC3. This is where the approval also is for atezo in IMpower 110. So if we talk about the patient characteristics, these both the arms of arm A and B, that is experimental and the control arm, they were well matched, and there were most of the patients had non-squamous histology in excess of 75%. Most of them had a good performance status of 0. About 60% of the patients in arm A and 45% of the patients in arm B had an age of less than 65. Next slide. So like I said, the primary endpoint was overall survival, and we are talking only about the high PD-L1 expression group. So we see that the overall survival in the high PD-L1 expression group was better in favor of atezo monotherapy compared to standard chemotherapy. The median overall survival, 12-month overall survival, was 65% versus 50%, and the median OS in numerical figures was 20 versus 13 months. So a 7-month OS benefit was seen with a hazard ratio of 0.59 and an impressive p-value. Next slide. Very interesting to look at the forest plot also. Most of the key subgroups benefited with the use of atezolizumab, be it the non-squamous histology or the squamous histology. Of course, the number of non-squamous was more than squamous. Also, it did not really matter whether the smoking history was there or not, and also almost equal results in both the genders as well. And there was no difference in the age also. Patients who were less than 65 or more than 65 also benefited well. So the end result was that it was almost all the key subgroups which had seen an improved overall survival with the use of atezo monotherapy. Next slide. If you look at the response rates, which was the secondary endpoint, this also was improved with atezo versus chemotherapy. Again, we are talking about the high PD-L1 expression population, 40% versus 29%. Next slide. Also interesting to note is that the OS benefit in the PD-L1 high subgroup of population for atezolizumab was maintained with the 2 clones of PD-L1 which were tested, 22C3 or SP263. We have seen Dr. Pasricha in the beginning talking about these 2 clones and how we really can use them interchangeably after the blueprint study. So this also is quite reassuring to see that irrespective of the clone used, there was a benefit of atezo monotherapy over chemotherapy in the high PD-L1 subgroup population. Next slide. If we look at the safety analysis, that also was consistent with the data which was presented earlier at the primary analysis. So not a real scare in that aspect. There were more immune-related side effects in the atezo arm and more of neutropenia and hematological toxicity in the chemo arm. But all of that is well known, and atezo monotherapy was well tolerated. Next slide. So that is why atezolizumab is one of the category 1 recommendations by NCCN in this particular subset of patients. And the patients have to have a high PD-L1 expression, and that is the most important thing one has to learn over here. Next slide. Now, so the summary is that 110 was a positive trial wherein a high PD-L1 subset of NSCLC patients, the high PD-L1 expression patients saw a statistically significant and clinically meaningful improvement in overall survival, and the numerical difference was about 7 months. The safety profile also was consistent with the prior observations. The immune-related adverse events, they were generally low grade, and the patients who were treated with atezolizumab had a longer treatment exposure than patients treated with chemotherapy. Next slide. Now talking about the recent study, which is atezolizumab in the early lung cancer, which is the IMpower 010 study. So what exactly does this bring to the table something which is important? And this was seen in patients with resected stage 1B and 3A, stage 1B to 3A non-small cell lung cancer. Next slide. So very interesting to look at the trial schema. This is the trial schema. So the patients had to have a completely resected stage 1B to 3A NSCLC subgroup of patients, and stage 1B tumors had to be more than equal, which is again understandable because these are the patients which are high risk subgroup of patients. Post lobectomy or pneumonectomy did not really matter. ECOG performance status of 0 to 1, and tumor tissue for PD-L1 analysis had to be available. All these patients, they were given standard chemotherapy, which is the practice. These patients are given standard chemotherapy, and this has been proven in the LACE meta-analysis or the other trials which were there in the analysis. So very importantly, that all the patients who were 1200 odd patients received chemotherapy. This was different from what was the study design of the ADAURA study. We've just discussed that study some time back, and the randomization was done after chemotherapy 1:1 to receive either best supportive care or atezolizumab in the standard doses for 16 cycles every 3 weeks, that is Q3 weekly. It was nearly about 1 year, and there was no crossover which was allowed. Now, the stratification was done according to histology, according to stage, that is 1B, 2, and 3A, according to the tumor expression of PD-L1, very important, high PD-L1 versus intermediate versus low. The primary endpoints were interesting, and I would just talk about that again in the next slides, is the hierarchical statistical design testing, which was again used in this particular trial 010, where initial primary endpoints were PD-L1, the TC score more than equal to 1%, stage 2 and 3A population. All patients, stage 2 and 3A population also was seen after that. And the third was intention to treat population, that is stage 1B, 2, 3A. And the key secondary endpoints was overall survival in the intention to treat population, and DFS in the high PD-L1, that is PD-L1 TC more than equal to 50%. And there they took only stage 2 and 3A patients. Next slide, please. So this is what I was talking about. This is the study design. The primary DFS endpoint was tested hierarchically in 3 primary analysis populations. Initially, it was DFS in PD-L1 more than equal to 1% TC score, stage 2 and 3A. If this was positive, then DFS in stage 2 and 3A in all comers, any PD-L1 expression is what we're talking about. Then if this was positive, DFS in the intention to treat population, which means stage 1B also included. And if this was positive, OS in the intention to treat population, stage 1B also included. Next slide. These are the baseline characteristics, and of course this looks a busy slide, but then very importantly, one has to focus on the fact that there were very less number of patients which were 1B, about 12% only. And talking about the percentage in terms of histology, most of them, they were non-squamous histology, about 65, that is to 2/3 of the patients were non-squamous histology. If you talk about the PD-L1 expression, the TC more than equal to 1% patients were almost in all the stages, they were about 55%. So more than 50% of the patients had a PD-L1 expression of more than equal to 1%. There were patients who were EGFR mutated, about 8 to 10% EGFR mutated patients, and about 3 to 4% patients who were ALK rearranged also. So this again is important because we'll be talking about this in the subsequent slides as well. Right. So next slide, please. The primary DFS endpoint was tested in the PD-L1 TC more than equal to 1% in stage 2 and 3A, and this DFS was met. So the primary endpoint of improved DFS in this particular population of stage 2 and 3A with PD-L1 expression more than equal to 1% was met. Next slide. And this is what we are talking about. If you look at the Kaplan-Meier curve, there is a good separation and a very early separation. And if you look at the hazard ratio, it is 0.66, which means that there is a 34% reduction in the risk of disease recurrence or death in patients who were given adjuvant atezo versus best supportive care. And this benefit is in addition to the previously established benefit achieved by the standard of care chemotherapy alone, because chemotherapy has been given to all the patients, p-value being 0.004, which is what was beyond the significance boundary for this. Next slide. If you look at the DFS benefit across the key subgroups of population, most of the key subgroup of the populations, they benefited. The benefit was more in the non-squamous histology as compared to squamous, but that is known. Also, if the EGFR mutation was positive or the ALK gene rearrangement was positive, the benefit was not seen as much. So this also is an important thing to understand. Next slide. I would like to reiterate here that if you look at the NCCN, the NCCN recommendation is that these patients who are early lung cancer patients and resected, the approval of atezolizumab is in patients who are having a stage 2 to 3A population, and these patients should not have any EGFR and ALK mutation, and they should then these patients can be given atezolizumab. So the approval is not restricted to the PD-L1 expression, but it is certainly bound by the fact that EGFR and ALK should be negative, and it is also important to note that in 1B patients NCCN does not recommend. Next slide. This is what we are talking about, is the next primary endpoint, the DFS in patients of all randomized stage 2 and 3A population. So this is what I'm talking about. This is what the NCCN guidelines also recommend, that irrespective of PD-L1 expression, stage 2 and 3A population, atezo can be used. And here the hazard ratio is 0.79 and the p-value being 0.02, which was crossing the significant boundary for DFS. And the Kaplan-Meier curves, as we see, they remain widely separated even after 4 years. Next slide. And interesting to look at the DFS in this key subgroup population as well, where we see that the improvement is more in the non-squamous histology. The improvement is less in patients where EGFR and ALK mutation is seen. That is why the NCCN doesn't recommend in that population. And the improvement has been seen in stage 2A, 2B patients also, and 3A patients as well. Very importantly, if you look at the improvement of the benefit, segregating them onto the percentage of PD-L1 expression, the most benefit is seen in patients where there is a high PD-L1 expression, again, which is understandable. And if you look at the TC more than equal to 1%, there also the diamond is in favor of atezolizumab. But where there is no PD-L1 expression, then the diamond is just on the line of unity. So, and the confidence intervals are also crossing that significant boundary. So probably there the benefit is not as much. Next slide. Yeah, again, there's the same thing which is seen, that in a patient in all randomized stage 2 and 3, an enriched clinical benefit was observed in patients whose tumor expression was on the higher side. And this is, we can see very clearly in this forest plot. Next slide. So if we talk about the further third primary DFS endpoint, which was that in patients who are having an intention to treat population from stage 1B to 3A, there the significance boundary was not crossed at this interim DFS analysis, but the final DFS analysis is expected further in this was 2022, but it has not come as of now. Next slide. Yeah, this is what I was talking about, that although the p-value is 0.04, but it has not crossed the statistical significance boundary for DFS, although the Kaplan-Meier curves are separating here as well. Slide. If you look at the overview of planned OS analysis, there are formal 5 OS analysis which are planned in the intention to treat population based on the statistical analysis plan and current event projection. The first formal OS interim analysis is planned when approximate 254 events are reached in the intention to treat population. This was presented in WCLC last year. Next slide. And there, if you look at the OS is still not mature enough, but the PD-L1 in the TC more than equal to 1% population of stage 2 and 3A, the hazard ratio is 0.71, but it is not statistically significant as of now. Next slide. And if you look at the other populations, which is the intention to treat population, including 1B stage or stage 2 and 3A without PD-L1 expression, there also the OS has not been found to be any better in the atezo arm compared to best supportive care. Next slide. But then we can safely say that the OS is yet to mature, and we can have some surprises in this space also in the coming time. Very importantly, it is interesting to note that if you're talking about the overall survival and we exclude patients of biomarker positive patients and take only the PDL1 PC more than equal to 50%, that is high PDL1 expression patients, there the Kaplan-Meier curves are separating widely and the hazard ratio is also 0.42. So this remains to be seen whether we'll have overall survival benefit or not. Although because it is an early lung cancer, it is going to take years for the overall survival result to come in. Next slide. Most of the patients, number of doses per cycle received, the median value was 16. More than equal to 16 was received by approximately 2/3 of the patients. So which means that the exposure also was good and these patients were able to maintain a good dose intensity. Next slide. The safety profile is also very interesting to note that there were no new safety signals which were seen, and atezolizumab, like in the other trials we've seen, had a few grade 3 and 4 adverse events and few serious adverse events which were manageable. Next slide. So the conclusion of this IMpower 010 is that it is the first phase 3 study of immunotherapy to demonstrate DFS improvement in the adjuvant NSCLC setting after platinum-based chemotherapy. All patients received chemotherapy. Adjuvant atezolizumab following complete resection and adjuvant chemotherapy showed a significant DFS benefit in PDL1 more than equal to 1%. Stage 2 and 3 and all randomized stage 2 and 3A as well, with an enriched clinical benefit in patients whose tumor express PDL1. DFS in the intention to treat population where the 1B also was included did not cross the significant boundary at this DFS analysis. The OS is also in favor of atezo, but it still remains to be seen. The safety profile was consistent with the prior experience. So with this, I thank you all for listening to this presentation. So now we move to the next part of our webinar, which is the use of durvalumab in stage 3 NSCLC. And we are talking about the PACIFIC study, and we are talking about the real world evidence, which is the PACIFIC-R study. And the PACIFIC-R study. And to take this forward, we have with us Dr. Bhavesh Poladia, who's a consultant medical oncologist from Tamil Nadu. Dr. Poladia, good evening.
Good evening.
Please take it forward.
Thank you. Thank you for the kind introduction, and thank you for the opportunity, Dr. Rajat Bajaj. So I hope I am audible and my slide is visible.
Yes, it is visible.
Okay. So we are just changing gears. Initially, we have spoken about everything which is early lung cancer, surgical cancer, or resectable lung cancer. So we'll change the gears and we'll see something which is unresectable, what to do about it. So we know the burden of lung cancer is not only high all across the globe, but also in India. We can see it is the 4th common cancer in all overall, and the 2nd common cancer, if we see, it is male specific. So not only that, but the incidence is also quite high, and the death rate, that is, we lose almost 90 to 92% of the patient after their diagnosis. And 5-year prevalence also, we can see that it is becoming better just because of the newer modality of treatment, especially in stage 4 also. So what is the problem basically? So here is depiction of the, just a second, give me. So basically what we are focusing here is the unmet need in stage 3 NSCLC, especially for those patients who are not resectable. So those who are resectable, they'll either undergo upfront surgery or they'll receive some kind of neoadjuvant chemotherapy or neoadjuvant combination of chemotherapy and immunotherapy, or and then they will undergo surgery. So there is a small percentage where the stage 3 NSCLC are not resectable. So this amounts roughly to around 10 to 15% of all the lung cancers. And what remains, the choice of treatment, that is either a concurrent chemoradiotherapy together upfront as a definitive thing, or we give a neoadjuvant chemotherapy and followed by reassessment. If there is good response, we give a definitive combination concurrent chemoradiotherapy. That is what we knew a few years back. And with this treatment, even though if it is a curative treatment, that is what we begin with. But what happens as a result? The median PFS remains just 8 to 12 months and very dismal 5-year overall survival, which is approximately 20%. So that's not really a very impressive result for stage 3 as we compare to any other cancer of any other subsite. Why does this happen? Because 50% of them will come with distant metastasis, and 40% will again show some kind of recurrence. So this is the evolution of treatment, especially in this unresectable stage 3. Initially, it started only around 50 years, 60 years back, only with radiotherapy alone. We did not have effective chemotherapy at all. But then in last 30 years, we have effective chemotherapy, and initially it was started sequential chemoradiotherapy. That is either the chemotherapy first followed by radiation or radiation followed by chemotherapy versus RT alone. And there was a moderate improvement in the overall survival. There was a 13% decrease in the risk of death. Moving ahead, they try to even use the concurrent chemoradiotherapy, and that again showed some OS benefit, 3-year overall survival benefit. There was survival gain of approximately 10 months. The 5-year overall survival also started improving. Recently, this was compared, the concurrent was compared with sequential, that is not less than 20 years back. And we see that there is not much difference in the OS benefit, very small difference, and very, very small difference in the PFS. Then comes the induction CRT versus the CCRT. Again, there was no major benefit in the overall survival compared to the conventional chemoradiotherapy combination. And then now the latest one is the consolidation. So consolidation versus CCRT, again, there was no major benefit. And of course, it was associated with higher toxicity when you use consolidation therapy post CCRT. It was not very easy for all the patients to tolerate. And everywhere you can see what has been used is the basically platinum-based chemotherapy. And there was hardly anything else which was showing any effect in this, especially this subset of patients. So this is the 5-year overall survival, which I was talking in this stage 3 so-called curative setting. And we have just a 5-year overall survival of only 15 to 25%. So even though the standard treatment was fixed and for almost 40-50 years, there was hardly any major change. But there was a unmet need that can this be improved further or not. So that is where the PACIFIC study comes. And this is a very good and nicely designed study where once the standard therapy ends, the patients are randomized to receive either placebo versus durvalumab for a year. And PFS and OS were the co-primary endpoint. We can see this is the intention to treat population curve, and an updated 5-year overall survival shows that there is a persistent improvement of around 9 to 10% starting from the first year itself, and it is still maintained even after 5 years. And if we see the median OS, it is 29 in placebo versus 47.5 months in durvalumab. So this is the first and the only approved IO, especially in this setting, to demonstrate almost 43% OS at 5 years, which is very impressive. Even the updated PFS, you can see there was an improvement of around 15-20% in the first year, and it has remained very nicely, almost 14-15% improvement in PFS is there even at the end of 5 years. If we focus on the median OS, so in the placebo, the median OS was just median PFS, it was just 5.6 months versus durvalumab, which was almost touching 17 months. So again, this not only improves OS, but has a good sustained and durable PFS, amounting to almost 1/3 of the patient who gets benefited and they remain treatment free. So hope for cure is what we wanted to do for stage 3, and that is what it has helped us to achieve. So 5-year survival is basically a very, very important landmark now, where it is spoken more in stage 3 and even in stage 4. Optimal CTRT followed by IO has thus become the standard of care, and converting basically all stage 3 patient into a chronic problem and a never progressing disease. That's what becomes the goal. So coming or inspired from that, this is a real world study, that is PACIFIC-R, which I'll be focusing right now. And this again follows the same principles of what PACIFIC was doing. And they also selected unresectable stage 3 NSCLC patient, treated them with CTRT, and then followed by durvalumab. So what did they see? This is the 5-year survival curves, the OS and the PFS, which we have already discussed. And here again, this was basically an international observation study, started in 2018, 17 to 18. And they observed the patient over 5 years to see whether what was seen in PACIFIC, does that translate into real world also. So we can see that the median time to initiate the durvalumab after ending the RT was 56 days, where else if we go to the PACIFIC study, they were trying to restrict it to 42 days. That's a difference. Overall, the median durvalumab treatment duration was approximately 11 months. The patient received a median of 22 durvalumab infusions. There were approximately 7% who received even more than 26 infusions. So what happens in real world is little different than the very controlled setting of trial. Usually we see that the responses are poorer, but to surprise us, the PACIFIC-R study, if we focus on the PFS, the PFS is actually better. The PFS in PACIFIC trial was somewhere around 17 months, but in this PACIFIC-R, the real world data, it is 21.7 months, which is actually 5 months better than the real trial. So how this has happened? There are certain points which we have to take it into consideration, that in real world PFS is likely to be overestimated. The points for that were Germany and UK sites did not collect the deaths that occurred prior to the study enrollment. Almost 50 early deaths were not counted. Probably that is one of the reasons. The RECIST criteria for tumor assessment was used heterogeneously across the country. Again, that is a second point. Assessment for progression in real world may not occur as frequently or consistently as in clinical trials. This is a very important point that we actually see it in practice. Till the patient is doing good clinically, even slight increase in the tumor, we do not consider that as progression, and we still continue giving the therapy. So these are a few of the points where probably this PFS in real world has shown to be better than the actual data. So if we study the PFS in this real world data, and if we split according to the PDL1, which is the first graph, we can see that those who had PDL1 of more than or equal to 1, those who were positive for PDL1, they had a good median PFS of 22.4 months versus those who were negative, which was 16 months. Stage-wise, stage 3A was doing better as expected. Histology-wise, non-squamous was doing better as expected. CRT, those patients who were having concurrent chemoradiotherapy, they were doing better approximately by 4 months. So after a good efficacy, we also have to focus on the toxicity. So that is what we try to analyze the data very critically. So durvalumab did have treatment discontinuation, and the adverse event, the reason of discontinuation was almost 16%. Pneumonitis was one of the very important features. There was a permanent discontinuation in almost 10% and temporary interruption in 5%. So almost 15% had some kind of interruption or permanent discontinuation. Moderate level events of ILD were almost seen in 8% patients. Median time of onset was approximately 2.5 months after starting durvalumab. Corticosteroid were required by almost 2/3 of the patients, almost 71%. So the summary of this specific R demonstrates that the durvalumab consolidation after the definitive CTRT is useful not only in trial setting but also in real world setting. Actually, it has shown a higher median PFS compared to the Pacific trial by almost 5 months. There are certain challenges of collecting the real world data that we all know. The effectiveness of durvalumab is consistent including the PD-L1 subgroups, and a rate of discontinuation is a worrisome thing. Almost 15% patient, 20% patients are not able to continue the therapy, and sometimes very small percentage, almost 30%, 26% of the patient may even have some kind of disease progression, which we all know. And coming to the toxicity, pneumonitis or interstitial lung disease is something which we have to keep our eyes, ears, mind, everything open, and and be very aggressive in the treatment, or else if it progresses unnoticed, it can be lethal too. I'll also share a little bit about this one retrospective data, that is a durvalumab spotlight real world study. This is again a phase 3 study. This is again a retrospective study where it is an observational cohort where again they are looking for the clinical characteristic, the treatment patterns, what are the adverse events, and the real world effectiveness in the same setting of unresectable stage 3 NSCLC who had received durvalumab as a consolidation therapy followed by definitive CTRT. So this was again the same, the schema is not much different. Inclusion criteria and exclusion criteria were almost similar. Baseline characteristics were also almost same. The median duration of CRT was roughly around 1.6 months, 1.5 months you can say. That's what is the usual 6 weeks, 7 weeks CTRT period. Almost 93% patient did receive the concurrent CRT, and less than 1% received sequential CRT. Induction chemotherapy was received in approximately 12% patient, and consolidation chemotherapy was received by 20% patient. Carboplatin based therapy was given in most of the patient, and combination of Pacli and carbo in around 73% of the patient. So this is the curve, and we can see that the curve looks quite impressive with median time from the end was 43 days, which is very, very close to the Pacific, that is 42 days. At the end of the cutoff of the study, that is 314 out of 322, so almost 95% of the patient had discontinued durvalumab, and discontinuation was seen approximately at the end of 9.5 months. 40% still did receive almost 11 or more than 11 months of therapy. So even the spotlight study showed that this is not a very easy therapy. It does have progressive disease, it does have toxicity, and they have segregated it into 3 months, 3 to 6 months, 6 to 12 months, and more than a year. So this is a chart which shows that with progressive disease, there is toxicity also what we have to handle and keep it under a very close watch. These are split up of the patients of the adverse event, the pain, the pneumonitis, and the esophagitis, which are very, very common. And we do see these patients having this problem of pneumonitis and esophagitis and pain associated with it, which is very, very common during therapy and after therapy. And it takes some time for patients to recover from these side effects. The time to first subsequent treatment was 17.5 months. So it is almost equivalent to a PFS, which is 16.7 months. Time to metastasis, the distant metastasis, was again impressive. 67% at the end of 1 year, and at the end of 2 years, it was 55%. So the PFS, as I have already mentioned, 17.5 months, a median PFS, and the PFS at 12 months was 58%, at the end of 24 months was 44%. Incidence of metastatic at first progression was maximum in the brain, followed by bone, and followed by lung itself. Adrenal and liver also contributed to the first site of progression in approximately 25% patients. There were 12% patients who actually died without progression. So they were unrelated deaths to the cancer. The first subsequent therapy following the discontinuation of durvalumab, again, patients did have different options, different therapies were offered, chemotherapy or immunotherapy or targeted therapy, and even surgery in some patients, especially those who had a very limited recurrence for that disease. So the key takeaway point from this real world data was that almost 93% patients did receive concurrent chemoradiotherapy. Most of them had just carboplatin based chemotherapy regimen. That was more common than the cisplatin based regimen. 52% patients did receive within 42 days of CRT, the ideal way of doing it, Pacific way. 40% did receive durvalumab for more than or equal to 11 months, again quite impressive. The adverse events were quite consistent with the Pacific trial, and the most common reason of discontinuing again was progressive disease in 21% patient and toxicity in 19% patient. 17.5 months was the PFS. And I would like to end here by saying that the people have not stopped here, and they are not happy with 43% of 5-year overall survival. They want to do better, and there is a trial ongoing right now by the name of Pacific 8, where after the definitive CTRT, the patients are being randomized to receive the standard of care, which is durvalumab versus durvalumab plus TIGIT inhibitor domvanalimab. So they are expecting that probably this is going to, cross the 50% barrier, and probably the 5-year overall survival will be better than 50%. So thank you for the patient listening, and I stop my presentation. Thank you.
Hello, thank you, Dr. Poladia, for very elaborately discussing the use of durvalumab in this setting of our patients. So, what is your average time when you start durvalumab in your real practice? Are you able to start as soon as 2 weeks or 3 weeks after CTRT, or do you generally start after 4 to 5 weeks or more than that?
So a very, very relevant question, because in Pacific 8, so we are participating in Pacific 8 as from our center, and the cutoff is 28 days. So out of 4 patients, what we have screened, only 1 patient was eligible enough to go onto the trial. So it is a very strict criteria what they are following. They are expecting that patients who are started within 28 days are doing better. And that's why these cutoffs have become much more difficult. It is not 42 days, but it is 28 days in Pacific 8. So what you are asking is a relevant question, and it is very difficult to take patients who have just come out of their concurrent chemoradiotherapy, and they are recovering, they are healing, their PS is becoming slowly better, small side effects of radiation and chemotherapy, they are recovering. So it is becoming difficult. So we want to start it within first 4 weeks, but sometimes we have to wait for even 6 weeks, or even more than that. Some patients even up to 8 weeks.
And do you do a CT scan at least in all these patients to see 2 things? One is, of course, the disease not progressing, and the other is that what is the the intensity of radiation pneumonitis, because these are the patients where there is a contraindication of the use of durvalumab.
Absolutely. So that is always there. So the one CT scan which gives you idea for both. Obviously, the patient, most patients are going to respond. Almost more than 40 to 50% patients are going to respond very nicely. At least stable disease and better. And those patients who are having some radiation pneumonitis, they are the ones probably are the patients who on use of immunotherapy also have some kind of overlapping symptoms of pneumonitis and interstitial lung disease. So those are the difficult patients because the lungs are already compromised, and again you are going to challenge it with the immunotherapy having similar side effect profile.
Right. Hello. Yeah. And the last question is that do you use durvalumab for all your patients, or do you restrict them to an enriched PDL1 population? If yes, what is your criteria? Because there are two different approvals. One from US FDA where we can use it in all comers, and the European guidelines recommend PDL1 more than equal to 1%. So what is your take on it? And the other is that are you doing EGFR and ALK before giving durvalumab maintenance?
Yeah, so as I told you, since we are the part of Pacific 8, so all our patients who are undergoing CTRT are getting screened for it. So those patients, so EGFR and ALK is an exclusion criteria. So all patients who are positive for EGFR and ALK cannot go onto the study. PDL1 is not a very strict criteria, but it should be just positive. They don't see whether it is 1%, 10%, 50% or what. But they are focusing patients who are PDL1 positive, who are negative for the driver mutation, that is especially ALK and EGFR. And that is how the patients are getting screened, and then they are taken up onto the study. So definitely no for ALK and EGFR. And PDL1, even 1%, 10% or 50%, everybody is welcome.
Okay, but then it has to be PDL1 positive.
Yes.
Yeah, so I think a very important message coming across that over a period of time, we probably will evolve in terms of usage of durvalumab maintenance. Even if the ongoing study comes out to be positive, durvalumab is still going to stay, at least in India, till the time the anti-TIGIT antibody is available. And there also we've seen that the most benefit is in patients who are having a high PDL1 expression. Cutoff of 25% is what was taken in this study. And the other is that the EGFR ALK should be negative, because EGFR ALK positive patients did not do as well, and the forest plot also showed that the line was crossing the confidence intervals crossing the line of unity. Right. Thank you, Dr. Poladia, for this very nice presentation, and stay with us for the rest of the meeting. Thank you.
Thank you so much.
Now, after this enlightening talk by Dr. Poladia, we come to the next talk, which is going to be on the use of EGFR inhibitors in metastatic NSCLC. And to discuss this, we have with us Dr. Ankit Batra, who is an assistant professor in the Department of Medical Oncology at HIMS, Dehradun. Dr. Batra, good evening.
Good evening, sir. How are you, sir?
Forward. I'm good. I'm doing well. I hope you are also good. Thank you.
Yes. So thank you, Dr. Rajat, for organizing a very wonderful CME and giving me this opportunity. So I'll be discussing. Am I audible?
Yes, you're audible.
And my slides are visible.
I not. No, right now they are not visible. Technical team, can you help? Yes. Now they are visible. You can put them in the slide share mode.
Okay. So I'll be presenting decoding the treatment options for EGFR, non-small cell lung cancer stage 4. So the stats have been beautifully described by Dr. Bhavesh in the previous slides. I'll just recapitulate once that we all know that according to 2020 data by Globocon, lung cancer is one of the most commonest cancer and the second most common cancer. But in terms of mortality, it is the most lethal cancer, and around 18-20% of the deaths are because of this malignancy. So directly coming to the EGFR subsite, I won't waste time in other subsite. So what are we looking for? When we choose a treatment, that is the first line treatment in advanced EGFR mutate non-small cell lung cancers, we have various factors to decide this treatment. And the first or the foremost, we think about the progression-free survival in our daily practices. But almost everyone would like to have a good overall survival as well. And the other factors which comes into our consideration are like overall response rate, presence or absence of brain metastasis, and especially with all other drugs, we used to see safety and toxicity profile. Quality of life is most important in stage 4 lung cancers. And the patient receiving subsequent therapy upon progression is one of the other factors. So discussing these factors one by one, We have seen that in FLORA trial.
Sir, can you please make it full screen?
It is full screen from my side.
It's okay. Can I run from my side? Because
Okay,
your
sure.
slide is not moving.
Is it moving now? Or you can run from your side also. No issues.
Yeah, sure.
Yes. Previous slide. So when we talk about EGFR mutated non-small cell lung cancers, obviously the most important thing is that we think of TK as the standard of care. And as the evolution of the TK have seen, we have seen that various trials and the median PFS on this with the trial. So the first and the foremost was the IPAS trial, which compared gefitinib with the standard of care chemotherapy. And we have seen a median PFS of 9.5 months. Then the other first line like erlotinib has also shown a median PFS of 11 to 13 months in various trials. When we come to second generation TKI like afatinib and dacomitinib, there is a slightly increase in the median PFS, but at the cost of various toxicities. And then we have the third line TKI, that is osimertinib in the FLORA trial. So in FLORA trial, we have seen that the median PFS is 18.9 months, which is unprecedented improvement in the PFS in the history of TKI in stage 4 metastatic EGFR mutated lung cancer. Next slide, please. So with respect to other trials like LUNGLUX 7 trial, we have seen that there is no significant improvement in the PFS as compared to gefitinib. And as we can see in this curves, PFS curve, that the separation started at around 12 months. Whereas in Archer trial, the separation started at around 6 months. Although the brain mets patient were excluded in this trial, and there was a slight 5 months improvement in the median progression-free survival. But whereas when we see the FLORA trial, which is osimertinib compared with the standard of care TKI previously used, and this trial also included brain mets patients who were stable, that were around 20% of the all cohort. But the main significant point is that the separation started right from the initial phases of the treatment, and that was a very important trial. Although there is a caution that cross trials could not be compared because we are comparing apple to oranges, so that is not significant. But as we do not have any head-to-head trials, so we have to see this factors in consideration for choosing the first line treatment for our patients. Next slide, please. Next slide. Similarly, the other factors are like overall response rate. So once we see PFS and OS, overall response rate is also very important. And similarly, in these 3 trials, we have seen that afatinib gives an overall response rate of 70%, whereas dacomitinib has given around 75%. Versus in FLORA trial, the overall response rate with osimertinib was 80%. So in that terms also, it is one of the highest in the evolutions of TKI, which we have seen in metastatic EGFR mutated lung cancer. Next slide. So osimertinib has shown maximum overall survival and duration of response also. So coming on to the overall survival, when we see the FLORA OS curves, we have seen that the median OS is with osimertinib is 38.6 months as compared to others first line or first generation, second generation TKI, which was 31.8 months. So there was a significant increase in the median OS with a hazard ratio of 0.79. The other things which we can conclude from this study is that median OS was more than 3 years, and osimertinib patients were more likely to be alive at second and third year landmark, which we'll be seeing in other future further slides also. And first time an EGFR TKI has translated a PFS to a significant OS benefit. Next slide. Whereas if we compare the OS in the LUX Lung 7 and Archer, we see that in the LUX Lung afatinib versus gefitinib, we do not see a significant OS benefit, which is 24 months with gefitinib versus 28 months with afatinib. So afatinib has failed to improve OS as compared to gefitinib. Whereas if we talk about the Archer study, which is with dacomitinib versus gefitinib, it was a hierarchical study. So although there is a numerical difference, improvement in the overall survival, But since the ORR, which was the second endpoint of the study, did not show any significant statistical significance, hence they have not concluded and reported the OS. Next slide, please. So on the base, next slide. So on the basis of this overall survival, also we can conclude that osimertinib is one TKI which has shown unprecedented improvement even in the overall survival. So if we look at 3 years, 28% of the patient in the FLORA study were still alive and receiving the osimertinib, which is 3 times more as compared to the EGFR first generation TKI, which was only 9%. And when this study was, the data cutoff was taken, at that time it was 22 versus 5%. So almost 4 to 5 times more as compared to the first generation TKI. Next slide, please. So other important factor when we choose a first line TKI is the presence or the absence of the CNS disease. And that is a very important factor, especially in our day-to-day clinical practice. And we have seen in this FLORA trial that even if a patient is with known or treated CNS metastasis, in that case also, the median PFS in the osimertinib versus the standard of care was significantly higher, which was 15.2 months with a hazard ratio of 0.47. Whereas without any known or treated CNS mets, it was significantly much higher, which was 19 versus 10 months, and with a hazard ratio of 0.46. So CNS progression event, which was seen in the osimertinib, were only 6% as compared to the first generation TKI, which was 15%. So almost 2.5 times higher as compared to osimertinib. Next slide, please. So intracranial PFS, we can see this intracranial PFS curves, which was significantly better as compared to the first generation TKI, and the median CNS PFS was not reached with the osimertinib versus standard of care TKI, which was 13.9 months with a hazard ratio of 0.48. So it was statistically significant with osimertinib as compared to the first generation TKI. Next slide, please. And similarly, as compared to the other studies like LUX-Lung 3 and 6, they have not seen the CNS PFS. They have only seen the systemic things, systemic PFS, and the systemic clinical benefit was not seen in that. Similarly, systemic and CNS clinical benefit were observed only in the osimertinib, and the Archer study also did not conclude that. So we have only one randomized control trial was one of the primary endpoints was CNS disease. So that was included with this slide. Next slide, please. So after CNS things, whenever we are giving any kind of drug, we are always concerned about the toxicity and the safety profile. So when we look into the safety profile, as with when we have seen with dacometinib, grade 3 and grade 4 adverse events were seen in 63% of the patient in the Archer, almost 2/3 of the patients. Whereas when we see the afatinib subgroup, grade 3 or more side effects were seen in 31% of the patient in LUX-Lung 7 trial. And when comparing these two drugs with the osimertinib, the grade 3 or more side effects were reduced to only 18% in the FLORA trial. So this is just a cross-trial comparison, which is not the standard of care, but still it gives a very beautiful idea that toxicity with osimertinib is significantly lower as compared to dacometinib and afatinib. Next slide, please. So in terms of other toxicities like skin, paronychia, diarrhea, and stomatitis, we can clearly see that these toxicities are also significantly lesser as compared to dacometinib and afatinib with osimertinib. Next slide, please. And so one of the important things in the treatment is the dose reduction because of toxicity and the quality of life. So we have seen in LUX-Lung 7 trial that with afatinib, 42% of the patient required dose reduction as compared to 2% with gefitinib. Similarly, in the Archer study, in the dacometinib group required almost 2/3 of the patient required dose reduction, which is very significant as compared to the 8% in the gefitinib group. When we see the FLORA study, the dose reductions were seen significantly, like it was not significantly difference between the first generation, second generation, or the third generation. So osimertinib dose reduction were only 5%, which was comparable with the gefitinib, which we have the longest or the most experienced TKI till now. So this also concluded that because of the side effect, because of the toxicity and the other issues, patients are not able to tolerate this second generation TKI, and a significant proportion of the patient, almost 2/3 of the patient, are requiring dose reductions, which is not good for the treatment and does not result into good PFS or OS. Next slide, please. So along with this, we have seen the quality of life. Quality of life was also not very good with the dacometinib as compared to the FLORA, where the global quality of life has improved from baseline in both osimertinib and the comparative TKI, which was again beneficial for the patients, because quality of life is one of the major things which we look in our stage 4 patients, which are just treatable and not curable. Next slide, please. So if we see just a diagram to show that if 10 patients of EGFR mutated NSCLC are started on first line TKI, so out of them, 2 out of 10 die during the first line or receive only palliative or supportive care upon progression, and they are not even tested for any progression to T790M mutation. So out of these 8, only 6 will receive testing, and out of these 6, only 50% will be able to have a positive valid result for T790M mutation. So this pictorial diagram shows us that how to sequence our first line TKI in a patient with EGFR mutated lung cancer. So if we sequence properly, like with the third generation TKI, so we are going to treat additional 7 patients which are missing on the second line treatment with third generation TKI. So this diagram beautifully depicts that 7 out of 10 patients who are started on first or second generation EGFR TKI will not be able to receive osimertinib in second line, which is a significant number. And it is very difficult to predict who will develop T790M mutation or resistance. So because of this and the data which has been shown in the FLORA, it has been recommended that the first generation, first line TKI should always be third generation. Next slide, please. So another thing is access to second line therapy. Like how many patients are going to access second line treatment in further lines or second line treatment. So this is just a comparison of various TKI trials done till date, and it has shown that right from IPAS in this only 76% of the patient were able to receive subsequent treatment, whereas in the later second line second generation TKI only 2/3 of the patient were able to receive. So overall only 1/3 of the patient will not have access to the second line treatment, and we are losing this 1/3 of the patient who can get benefit if a proper sequencing can be done with this TKIs. Next slide, please. So just to discuss the real world evidence of T790 mutation, that there are a few studies, like one of the Japanese studies, 43% of the patient only developed T790M mutation, and they are only eligible for third generation TKI in second line treatment. Whereas one of the Taiwanese studies also showed 48% only patient developed T790M mutation after afatinib, and in another Taiwanese study it was around 32%. So with these studies, it's like just 30 to 48 or 50% of the patient will be eligible for third generation TKI in second line treatment. Whereas in most of our practice, we see that our patients, they are roughly around 50% of the patient only will develop this mutation, and out of them 2/3 only will be able to get access to osimertinib. Next slide, please. Next slide. So sequencing of this EGFR TKI is very important, starting with the prior generation EGFR TKI and then treating those who develop EGFR T790M mutation is one of the options which we used to practice earlier. But over the years, we have learned that this is not optimal clinical care, because we are not able to predict who will develop EGFR T790, and that we can conclude only once the patient has progressed and has been tested for the same. And not everyone will be well enough in terms of PAS, GC or logistics to get additional treatment, and 30%, like 1/3 of the patient in the real world, are not receiving this second line treatment. Other issues are like technical problems with the tissue or liquid biopsies, which are not obviously every time yieldable or successful. And we have enough evidence that osimertinib is associated with a significant PFS and OS benefit when used in a first line therapy. Next slide, please. So there are various uncontrollable factors in sequencing which are not under our control, is like toxicity to the drugs, occurrence of T790M mutations, site of progression, whether it is intracranial or extracranial, oligo progression or other things, then concurrent morbidity, and obviously patient choices. So these are factors which are uncontrollable and can be improved by properly sequencing third generation TKI as a first line. Next slide, please. So we have various real world studies with first line osimertinib as well. So first one is the FLOWER study. We all know that it was a real world inter-regional prospective study. It was a various 9 centers in Italy and was done over a period of 2 years. So it has shown that the median progression-free survival was 18.9 months, which was replicating the FLORA study. And the median PFS in patient with or without brain mets was also significantly higher, which was 13.3 months. And with or without symptoms also was 15.5 months. So it has almost replicated the trial design and the trial study, which was the median PFS in different settings was also similar. And in this study also that EGFR 19 was almost 15%, L858R was 43%, and rare mutations were around 5%. Next slide, please. So when we see the side effect profile in this large study, most of the side effects were common one, like diarrhea in 40%, skin rash in 33%, paronychia, which was well expected and matching the trial design of the FLORA as well, or results of the FLORA as well. But one of the most common severe adverse effect was venous thromboembolism, which was around 8%. So this was one of the things which were observed in the real world setting, and it's needs to be like, it's more frequent as compared to the FLORA study and needs to be more monitored. Next slide, please. So other real world evidence we have from OSIFACT, which was a retrospective multi-center cohort study done in Japan. And this also has replicated that the median time to progression was 19 months. And in various settings or like different types of mutation, like 19 deletion, it was shown to have more effect as compared to L85, which was replicating most of the other studies, and no significant other difference was seen. And overall response rate in this study was also 76%. And the division within the baseline EGFR mutation was also similar as seen in the previous studies. Next slide, please. So when we see the side effect profile in this, pneumonitis was one of the things which was concerning. And if we see all grade, it was around 13%, and grade 3 or more was around 5% pneumonitis. So the discontinuation rates with the other EI were almost similar, but pneumonitis requires further investigation and follow-ups in these kind of patients. And this was one of the side effects which needs to be monitored more. Next slide, please. So the third real-world evidence study was from Mykonos. It is a global observational study which was done in various countries like US, Japan, Germany, and China. And based on the first data cutoff, which was very like low follow-up, it is also replicating whatever previous studies have been shown, but more long-term outcomes will be evaluated later and needs to be observed before commenting anything on this study. Next slide, please. So let's see what the guideline says. The NCCN guideline says that any patient with EGFR exon 19 or L858R mutations, if they are being diagnosed upfront before any treatment, then obviously osimertinib is the preferred treatment, which is category 1. Whereas even if we have started the systemic first-line systemic therapy and then we are getting these results, then also it's both way. Either we complete 4 to 6 cycles maintenance therapy and then interrupt, or interrupt then and there and then start osimertinib, which is also category 1. Next slide, please. So ASCO, what does ASCO say? The therapy for stage 4 NSCLC with driver alteration, osimertinib monotherapy has strong recommendations as compared to first and second generation TKI with or without VEGF inhibitors. They are moderate, and monotherapy with other TKIs is also weak. So the first line treatment with osimertinib is the standard of care as per ASCO guidelines also. Next slide, please. So to summarize, osimertinib is the only EGFR TKI which has demonstrated a clinically and a statistically significant improvement in overall survival. The median OS has been greater than 3 years, which is a new benchmark and a window of opportunity for management of patient with stage 4 NSCLC with synthesizing mutation. And it has become first-line therapy with most of the guidelines. FLORA is the first time an EGFR TKI which has translated PFS into an OS benefit, whereas all other studies have not translated that PFS into an OS benefit. And nearly 30% of the patients remained on osimertinib at 3 years. And osimertinib has a significant benefit in patients with brain metastasis, and it is one of the more safest and the least toxic drugs among the TKI options we have available. So sequencing the right TKI is most important, and consider that the best strategy with 70% of the patient, because they are not eligible for osimertinib in the second line. So all this evidence which we have till date affirms that osimertinib should be used in first line TKI for metastatic EGFR mutated NSCLC. Thank you. So with that, I would like to hand over to Dr. Rajat, and would like to ask any comments or any questions or anything from the other speaker.
Thank you, Dr. Ankit, for a very nice presentation on the use of osimertinib. In your practice, are you resorting to the use of osimertinib even in L858R patients, or are you tilting more towards the second generation TKIs?
Practically most of my patients till date have been very elderly. We have tried to use afatinib in a few patients, but the toxicity has not allowed us to continue the same, and ultimately we have to resort back to osimertinib.
Okay, so which means that if toxicity is not a concern, L858R patients, you would like to use second generation over osimertinib?
So there is a good data with EGFR and VEGF inhibitors combination, but practically I have not used that combination till date, and just searching for the right patient to do that till date. But yes, my preference would be like to use erlotinib with ramucirumab in that setting. Hello.
Yes, sir. Your voice is audible. Actually, Rajat sir is in mute.
Hello, am I audible?
Yes, sir.
Is Dr. Batra there?
Yes, I am here, sir.
Yes, so I'm saying that according to you, DEL19 and L858R should be treated differently.
So we have evidence that L858R, when we use erlotinib with VEGF inhibitors, the PFS is better. But practically, I have not used that till now, and because of other reasons like toxicity with afatinib and dacopatinib, we are still using osimertinib. But yes, definitely the data is good enough even for erlotinib and VEGF inhibitors.
Okay, and what is your take on the use of PFS as one of the important endpoints in clinical trials nowadays, and that is one of the reasons that osimertinib has stood out, compared to second generation TKIs, where the PFS has been to the extent of only 14 months, but here it is about 18 months. So and in that aspect, the relay study talking about the the use of erlotinib with ramucirumab giving us a PFS of about 20 months in all comers, both DEL19 and L858R combined, or rather in DEL19 to the tune of 24 months. Do you think that that also can be one of the competitors for osimertinib? or would you like to prefer that combination over osimertinib because of the higher PFS?
No, sir. Definitely, it's one of the good options and a competitor for osimertinib. But I think we need a head-to-head trial for the both. And any patient who has logistics for osimertinib, then that combination is definitely a good option.
Sorry, I'm saying that the finances is not an issue. Finances is not an issue. So do you think that that combination is better than osimertinib?
So numerically, definitely better, sir. But with that combinations, the frequent visits and intravenous drug usage is more. So in that sense, if most of our patients like with stage 4 lung cancers are elderly, I would like to use osimertinib only. Can you hear me?
Yes, sir, your voice is audible. Rajat sir, are you there? I think some network issue of Dr. Rajat Bajaj, sir.
Okay, no issues.
Yes, I guess there might be some network issue from Rajat Bajaj sir's end. So thank you all for joining us. We will be back tomorrow at the same time. Good night.